Namaskar, good evening everyone. May I request you all to kindly be seated. Kindly settle down as we are about to begin the program. May I remind you all to kindly switch off your mobile phones, or you may put them on silent mode, please. So namaskar, good evening everyone. On behalf of Walter Bushnell Healthcare Foundation, I extend a warm welcome to all our distinguished guests at this very special evening. As you all are aware that every year we organize a scientific symposium to address the key issues in the field of Obs and Gynae, along with the IOG Dr. Satyapal Awards and Oration Lecture, which is attended by a galaxy of esteemed national and international faculty. So once again, prior to the 6th IOG Dr. Satyapal Awards and Oration Lecture this year, I am very delighted to welcome all of you to one of its kind symposia with 4 scientific sessions with leading national and international luminaries on the most happening topics in the field of Obs and Gynae. I'd like to inform you that the entire proceedings of the evening are being broadcast live globally. In fact, many of our well-wishers, both from India and abroad, have already logged in to watch this session. A very, very hearty welcome to all of them as well. Welcome. It's a great honor to have amongst us Mrs. Sushma Paul Berlia. We'd like to extend a special welcome to ma'am. She's the co-promoter and president of APJ Satya and Swaran Group, chancellor and co-founder of APJ Satya University, and chairperson of APJ Education Society. Mrs. Sushma Paul Berlia, daughter and the only child of Dr. Satyapal, is a leading entrepreneur, a passionate educationist, a dynamic and innovative leader in the pharmaceutical industry, and a champion of gender parity and human values in all that she does. Leveraging her twin roles as an industrialist and as an educationist, she's been a pioneer in fostering industry and academia linkages at many levels. Ma'am was the first ever woman to hold a multi-state apex chamber in India as president of PHDCCI. She's a highly decorated person who has been a recipient of many awards and honors. And I now request Dr. Manju Purohit to extend a floral welcome to Mrs. Sushma Paul Berlia. We would also like to welcome the youngest member of the family, Dr. Neha Berlia, a member of the management board of the APJ Satya and Swaran Group. Dr. Neha Berlia, granddaughter of late Dr. Satyapal and daughter of Vijay and Sushma Berlia ji, is a dynamic and brilliant scholar. She's actively involved in infrastructure processes and high-impact projects of the APJ Satya and Swaran Group. I request Ms. Subuhi to give her a floral welcome. Thank you, Dr. Neha, for gracing the event. And now I'd like to welcome Mr. Nishant Berlia. Mr. Nishant Berlia is member management board, APJ Satya and Swaran Group, and alumnus of Stanford University, USA. Mr. Berlia has worked with the group's operations in India, Europe, and the Middle East, and is actively involved in the group's pharmaceutical vertical. He is currently the chairman of the PhD Chamber of Commerce and Industry Health Committee, member of the Federation of Indian Chambers of Commerce and Industry Pharma Committee, Life Sciences and Council, and Intellectual Property Rights Committee. Eldest grandson of Dr. Satyapal and son of Mrs. Sushma Paul Berlia and Mr. Vijay Berlia, Nishanji is also involved in various social causes. He is also the General Secretary of the APJ Education Society. I now request Mr. Vikram Narang to present a floral welcome to Mr. Nishant Berlia. And now may I request Nishanji to kindly come on stage and give a small introduction of Walter Bushnell and Walter Bushnell Healthcare Foundation. Mr. Nishant Barlia.
Thank you, Chief, for the very kind introduction. First of all, I would like to, respected chairpersons, eminent dignitaries, ladies and gentlemen, I must say it's such a pleasure for me to be standing here and seeing so many of you in our journey over the so many years in Walter Bushnell. We've come such a long way with your support, your guidance, your blessings. And today, really, the galaxy of eminence that we have today, it really warms our heart, and we're most grateful and humbled by your support in that regard. I thought I'd take a couple of quick minutes to share with you an organization, of course, which you know well, our organization, Walter Bushnell. Walter Bushnell is part of the APJ Satyan Savran group. And as you know, it has a very rich heritage. It was founded pre-independence and has been known as one of India's most innovative companies with a focus on innovative therapies and evidence-based medicine. We have a legacy of pioneering unique, innovative, first-time in India products through our own R&D as well as with the support of many international alliances. With your support, I'm delighted to share with you that we are now ranked 34th All India by prescriptions, which is, thank you. And what is remarkable and what I feel we are very proud, thanks to your support, is that we have moved from rank 48 in just last 5 years. And in fact, it's quite a big achievement from, I would say, and we're very grateful for our support for it because, as you well know, we don't cover all therapies as well. So really, we're very proud. And in fact, what I'd also like to add to this is that among the molecules that we are there, the representative market, what we call, we're actually number 1 by prescriptions. So thank you for your support. We are also acknowledged as one of the fastest growing companies in India. The latest CMARC and AVAX are secondary market research data reports. And in fact, AVAX actually mentioned there's a summary which goes to all the entire industry every month. They specifically identified Walter Bushnell as one of the fastest growing companies in the country. So thank you again for all your support. And with that support, we've been able to build some of the marquee brands which are so well known to you: Drotin, Urospas, Microgest, Gestin, Menusmin, Valist, Smartinor, and of course Overgen, amongst many others. We assure our continued commitment to 3 areas, and we feel it is with these foundations and your support we've been able to achieve this. One has been a science-led medicine. I'm sure you'll be glad to know that every claim, every discussion we have our own internal journal clubs, we have our own internal discussions on guidelines, and we actually grade our various claims also on the basis of grades of evidence. And we're very delighted to share those grades of evidence also with you. And that is the type of approach that we've been having. We have been supporting a large number of clinical trials, including phase 4 studies for multi-center, double-blind RCTs and meta-analysis. In fact, I'm delighted to share with you that, for example, if you were to go on PubMed today and enter Drotaverine, or the top 5 links, 2 will be links to studies that we had sponsored and have been published in high-impact factor journals. We have an extensive pharmacovigilance program, which I would say one of the most advanced in the country. And we are very upfront in sharing about whatever data we have vis-a-vis adverse reports. We have a very extensive cloud-based reference library. For each molecule, we probably have thousands of references. And because it's cloud-based, we can rapidly search through them as well. And that's one of the scientific support services also we offer. And I think what we are most proud of late has been our innovative R&D and patent library. I'd be glad to share with you that now we have products which are in the preclinical phase, the phase 1 phase, and the phase 3 phase. And in fact, only a couple of months ago, we received an award by the Legal League, which is an alliance of the top law firms, for being the most innovative company in the pharmaceutical space at the annual summit. So we're very proud and grateful for your support in that regard. We also have very high quality standards. Our plants include accreditations from US FDA, EU, and rarely Ministry of Health, Japan. In fact, our hormones plant, I'm delighted to share with you, just very recently had a 5-day FDA audit. And not only we sailed through that audit very, very well without any red corners, which I'm sure you've been hearing about, but we were especially commended by the FDA for data integrity, which meant that whatever data we were generating and the quality standards that we were having were kept very, very high. So it was a very proud achievement for us. We are also very happy to share that we have a unified quality for all our territories and jurisdictions. So since we discussed hormones, for example, the same hormone that we're exporting to US, Europe, or Japan, the same hormones we're also, the same quality standard we maintain in India, which is, we feel, because we believe Indians deserve the best as anywhere else in the world. And that's something we've been very proud of. proud about. We have a large system availability and reach. This year, there's been a lot of disruption, as many of you know, thanks to implementation of GST. But I'm delighted to share with you that we were probably one of the very few companies, not only on the pharma industry, but perhaps across industries, which in the morning of 1st July had opened billing. And the exercise required for doing this was mammothean. Our AP systems were up, but it gives you the strength of the system that we have. We have a network of almost 2,000 wholesalers, which cover over 500,000 chemists. And I'm delighted to share that today we have coverage of almost 5,000 towns or clusters, as we call them. So very deep coverage for many of our main products which are there. We feel these are things which mean a lot to your value prescription, and we're very glad for it. Most of all, I'm delighted, as always, to share that this program has been supported by the Walter Bushnell Healthcare Foundation. The Walter Bushnell Healthcare Foundation is an interdisciplinary center of excellence at the APJ Satyam University and is engaged in information dissemination and dialogue on critical and emerging issues in the Indian context. And we're very honored to have the opportunities to support through the foundation various conference, symposia, and lectures such as this today. So thank you once again for your indulgence, and most of all for all the support and your kind presence here today. Thank you very much.
So taking great strides in the field of medicine is the Walter Bushnell Healthcare Foundation and Walter Bushnell Healthcare. And Mr. Nishant Balya just apprised us of the same. So now we're beginning with the scientific sessions. In the first session, the topic is oral contraceptives from menarche to menopause. I invite on stage the chairpersons of this session, Dr. Rishma Dhillon-Pai, Dr. Anjali Tempe, Dr. Ratnabali Chakrabarti, and Dr. Chandravati, and Dr. R.P. Sonabala. I request all of them to kindly join us on the stage. We'd also like to extend a floral welcome to all of them. Oral contraceptives from menarche to menopause. That's the first topic of the day. And as they are taking their seats on stage, I'd like to introduce all of them one by one. We begin with Dr. Rishma Dhillon-Pai. Dr. Dhillon is a consultant gynecologist, Leelavati Jaslok and Hinduja Healthcare Hospitals, Mumbai. She's also the present Foxy President and recipient of many national and international awards. She has given 25 orations and was the invited speaker at 340 national and international conferences. She has also organized 33 conferences in the capacity of organizing chairperson and secretary. Dr. Tempe is our other guest on the stage. She is the director, professor, and head of the Department of Gynae, Maulana Azad Medical College. She has a teaching experience of more than 30 years and has published more than 50 papers in national and international journals. She has published 4 books as an editor and 25 chapters in various books. She has more than 200 presentations in various conferences and has also received an appreciation award from Delhi government for SOPS. We also have with us Dr. Ratnabali Chakrabarti. She is consultant of Gynae, Columbia Asia Hospital, ILS Hospital, Fortis Hospital, Kolkata, director of MAGS Medical and Research Center Private Limited, founder secretary of Indian Menopause Society, Kolkata chapter, elected president of the Indian Menopause Society 2018-19. She has also several publications and presentations, national and international journals and congresses. We have with us Dr. Chandravati, Director, Proprietor, Krishna Medical Center, Lucknow. She has a number of publications to her credit. She has published more than 50 papers in various national and international journals and has guided over 150 theses of students. She is the recipient of various awards from central and state governments for family planning. Dr. R.P. Soonabala is also with us. He's the head of the Department of the Breach Candy Hospital, Mumbai. He's the recipient of many prestigious awards, including the Padma Shri, awarded by the President of India in 1991, in recognition of work in the field of family planning. He's well known for his original contribution in the field of contraception, population control, and infertility management. He is the chairman, ICMR Working Group on Contraception and expert committee on the intrauterine devices. And the speaker for this session, Professor Caroline Westhoff. We'd like to invite her on stage, Dr. Professor Caroline Westhoff, who has come all the way from US to join us this evening. Let's hear it for her. She is the esteemed speaker for the 6th oration lecture, A Pill in Time Saves 9, of the IOG Dr. Satyapal Award function, which is being held tomorrow at the same venue at 10:15 a.m. She is the director of the Division of Family Planning and Preventive Services and of the Family Planning Fellowship in the Department of Obs and Gynae, Columbia University. Sarah Billinghurst Solomon, Professor of Reproductive Health, Columbia University Medical Center, Professor of Obs and Gynae, and Professor of Epidemiology and Population and Family Health at Columbia's Mailman School of Public Health. Attending physician at New York Hospital, published over 200 scientific articles relating to safety and effectiveness of contraception and abortion, principal investigator of the National Institutes of Health's Contraceptive Clinical Trials Network, editor-in-chief of the journal Contraception, a monthly publication for the advancement of reproductive health, senior medical advisor to Planned Parenthood Federation of America, Institute of Medicine, National Academy of Sciences, elected 2007. In 2010, the Society of Family Planning recognized her accomplishments, honoring her with a Lifetime Achievement Award. I now request Ms. Caroline to kindly make her presentation. Thank you.
Thank you very much. I'm honored to be here. Thank you for the kind introduction. And I think I have such esteemed colleagues, and I know in this country you rely a great deal on the IUD, and you've been led in the knowledge of the IUD, but today I'm going to talk to you about the birth control pill, which is not quite so widely used here, and think about the role of the birth control pill among women in a range of ages. This is where I work in New York, a large academic medical center, and one thing that is a little unusual is that our family planning clinic is a federally funded family planning clinic for poor women that is affiliated with the University Medical Center. So that makes it a perfect area for us to do research, but still a comfortable place for the patients. And it is located just a block away from the main hospital, but more accessible to the neighborhood and friendly for the patients. Okay, there we go. So I think one of the concerns that has arisen, starting with the very beginning of the pill, was the concern of the dangers and side effects that go with the pill. And many people continue to be afraid about using the pill because they view it as risky. Now, looking at this slide, the blue bars here represent the death rate among women who are using no method of contraception, and the deaths specifically related to pregnancy. These data are at least 20 years old from the United States. They appear to be an undercount, and we've gotten better at counting our own maternal mortality in the last couple decades. But what is true in all countries is that the death rate associated with pregnancy goes up with age, and you see The youngest women here, the blue bar is very small, and it increases. So if a woman uses any kind of contraception, she will reduce her risk of death because contraception is always safer than pregnancy. And sometimes we forget about this because we think of the pill being very dangerous, but the pill is not as dangerous as maternal mortality. So obviously, for all of us in OB/GYN, when a woman wants to have a baby, we will take care of her as best we can, regardless of her medical situation, and get her through all the complications. But nonetheless, this is not always successful. If a woman doesn't want to be pregnant, using contraception will help prevent those unintended maternal deaths. And in this chart, the little yellow bars represent using the birth control pill. And the reason I want to point this out is even though we think of the pill as being dangerous, it has very few deaths compared to pregnancy. So each of these bars represents the deaths that might occur in childbirth and also deaths attributable to the method itself. So this is, and the pill is very, very safe. So for a woman who doesn't want to get pregnant, the balance is definitely in favor of using this method, even though many people have an erroneous idea of how dangerous it is. In any country or situation, the higher the maternal mortality is, the greater the benefit of using contraception in terms of saving lives. And when we interview at our medical school the fellows who want to do high-risk obstetrics, I am joking with them a little bit when I say if they want to save women's lives, they need to do contraception because it will have the biggest possible effect. So in terms of recognizing the possible dangers of the pill and making sure that we actually do use it as safely as possible, the World Health Organization has developed an assessment system called the medical eligibility criteria. And the medical eligibility criteria is an evidence-based approach to deciding whether women can safely use each of the different methods of contraception. It is a formal guideline development process. I've mentioned, and it is an international committee that I'm a member of, but there are few people mentioned at the bottom of the slide who are Indian representatives to this committee. And it meets every few years to update the evidence and really decide for which women using the pill is safe, for which women using the IUD is safe, and so on. So it's a guidance for healthcare workers at all levels. In India and in the United States, not all healthcare is provided by the academic professors such as the people in this room, and the medical eligibility criteria helps even less trained people provide contraception more safely. So on the background of this consideration of safety, I want to look at using birth control pills specifically at all the different phases of reproductive life. I'm going to concentrate on the teenagers, on the time postpartum and lactation, and on the perimenopause, because the times in between we'll just have to accept by extension. In the United States, we also use contraceptive patches and rings, which are, in terms of risks and benefits, really fairly equivalent to the pill. But I will be speaking specifically about the pill, but the comments are applicable to these other methods as well. So in the United States, you can see in the teenage years, and I hope you can actually see this from the beginning of the room. It looks a little smaller than I expected, but the teenage years are a time of rapid onset of sexual activity, and this is also a time for rapid interest in adopting a birth control method and delaying a first pregnancy. I don't know what the age at sexual debut is in India, but since the average age of first birth is below 20, I must presume that the teenage years here also are the main time for the onset of sexual activity. What do teenagers worry about? Well, probably one of the very first things they worry about is whether their parents know whether they're sexually active and whether they require parental consent to seek medical care. In the United States, this varies, and there are actually individual laws in all 50 states regulating this. But in New York, where I am, and in most states, teenagers can receive medical care for reproductive health purposes without their parents' consent and with full confidentiality. So not everybody realizes that, but that helps us provide care to teenagers. Teenagers are largely worried about the same things that all women are worried about with beginning a contraception. I know everybody here in this room has heard these questions. Is this going to affect my fertility when I want to have a baby? And is this going to give me cancer? And I think teenagers are a little more concerned about fertility because of their youth and they have not yet been fertile, and they're a little less concerned about cancer because it is too far in the future. But in the interests of time, I'm not going to go into the vast literature we have now showing that the pill does not interfere with fertility at all. In the very early days of the pill, when the doses were very high, there was some delay in the resumption of ovulation for women after discontinuing the pill, but in fact that is no longer true with the low doses we use today. And in fact, the reverse is true. If a woman misses just a few days of these very low-dose pills, then she's at risk of becoming pregnant. So fertility, we can reassure our patients in this young age group that taking the pill as teenagers is not going to interfere with their future fertility. We also know that on average, taken together, the pill largely protects against cancer and doesn't cause it. More about that later. A key concern for teenagers in the United States is that the pill is going to make them fat. Teenagers are very concerned with their appearance, and that is a very big concern. Certainly for a lot of studies that we've done with the pill, we find the youngest girls are not interested in participating in the studies because they're afraid the pill will make them fat. Now, the Cochrane collaboration has done a review of contraceptive pills and weight gain, and this is not the sort of information that's very friendly to patients. At the time of the last review, and I collaborated on these, there were only 3 placebo-controlled randomized trials looking at the pill and weight gain. None of them found any association. There was no difference between different pills that was substantial. And overall, they could say there was no large effect. There was less data regarding progestin-only pills, but again, no apparent effect. But everybody knows Cochrane reviews tend to be massive and dense and not so easily patient-friendly. So we did want to look at this ourselves. In a study that we were doing actually about effectiveness of the pill at different weights, we enrolled both normal weight and obese women, and we had them at the beginning entrance into the study stripped down. We weighed everybody in the study on the same Takeda scale, and then when they exited the study 3 months later after using the pill, we repeated this, and these graphs are what the weight change was like in the course of the study. Now, this is a short-term study, but it does agree with longer-term data as well. And in the normal weight women, you see really a perfectly shaped bell curve where most women are centered right over 0 weight change, and there is equal weight gain and weight loss among the women in the study. And for the obese women, the distribution is a little broader, but it is the same distribution. And I think for us to reassure patients they won't gain weight on the pill, it's important for us to believe it. And so I wanted really clear data for myself so that I was going to be in a position to say this is not a problem for you. It is, appearance is very important to many people, and so it should be, but particularly for teenagers. And it is always a big conversation in the United States where overweight is an epidemic, to help people understand it is not because of the birth control pill. And as I point out to my patients, men are getting fat, children are getting fat, old people are getting fat, and they're not using the pill. This is not what the reason is. Now, in terms of another issue with regard to appearance, the clinical trials showing that combined hormonal contraceptives can reduce acne is something very encouraging for them. Also for the young teens who can end up in the hospital because of heavy bleeding due to anovulatory cycling, the pill can prevent that, and of course dramatically reduce dysmenorrhea. So these are all quality of life issues for teenagers, and very important in getting them to appreciate the benefits of this method in their life. Going back all the way to 1991, the American College of Obstetricians and Gynecologists, which is the national equivalent of your India OBGYN Society, published a committee opinion on the safety of using oral contraceptives for teenagers. This was published in the FIGO journal, and so at least in our country for a long time, there's been complete acceptance that this is a safe method for the teenagers. And what you will see here is looking at our birth rate by age subgroup for the teenagers. Just around the very same time of that FIGO opinion is when we started to see a dramatic drop in the teen birth rate in the United States, and it has dropped over 50% in recent decades, which is a good thing because we had the highest teen birth rate in any of the European and American countries, and it is an embarrassment to us, and it does not fit in culturally. And I think the much greater access to contraceptives, and particularly oral contraceptives, is really attributed with the credit for making this happen. Now, moving on to the next phase of life when women are planning pregnancy, it would be great if everyone had a complete preconception assessment before they stopped contraceptives. I don't know about here, but I could guess that, like the United States, this doesn't happen very often. We have a rate of unplanned pregnancies of over 50%. And of course, one of the big issues is we would like women to be completely adequate with folate before they become pregnant. The idea of giving folate supplementation after the woman already knows she's pregnant is typically too late to prevent neural tube defects. Certainly one company has put folate into the birth control pills. It took me a while to get used to that idea. And many people said, oh, well, you're just assuming the pill's going to fail, or you're assuming she's going to mess up. But in fact, I think it's great to make sure a woman's body is folate replete before she actually attempts pregnancy, because that's where she will have the maximum health benefit. In the U.S., we did an analysis of 1,600 women coming to our clinic for a pregnancy test, and we gave them a standard food frequency questionnaire from Harvard University, and we also measured blood levels of folate. We followed this up with another clinical trial, but what we found out is there are young women having unprotected sex. Over 25% of them had very insufficient intake of folate at the time they became pregnant. I was able to find a few studies in the literature from India also suggesting a high level of inadequate folate intake in your reproductive age women. So it's something we all have to pay attention to. And if we're giving women the pill during the years or short time before they're going to be pregnant, it would really be great to be giving them folate too. Now, one of the most important things we've learned, and we learned it a long time ago already, decades ago, is if a woman is accidentally exposed to the pill at the beginning of pregnancy, it is harmless for her health and it is not teratogenic. And so the idea that a woman needs to take a rest before she gets pregnant or take time off is really quite unnecessary. The other thing is that, again, with today's low-dose pills, the return to fertility is extremely rapid. One thing that might happen is if she gets pregnant shortly after finishing the pill, her dating might be off. She can mistake a pill withdrawal bleed and a real period for each other, and so for these women, I notice they often might be 1 month less pregnant than they think we are, and we have to be careful in dating them. But there are absolutely no concerns about women using an oral contraceptive right up until the time she plans to get pregnant. And after pregnancy is a slightly different matter, and I will show you what the medical eligibility criteria show shortly. But we all know that short interpregnancy intervals are dangerous for the mother, dangerous for that first baby, dangerous for the second baby in terms of all sorts of health risks, and that the more pregnancies, the more problematic that is, and that it also, at least in the United States, has a big social impact on the entire family if the babies are too close together. And so that emphasizes the need for contraception shortly after giving birth. Fecundity postpartum is variable, and cultural practices around postpartum abstinence are variable. Whether lactational amenorrhea is truly effective as a contraceptive method is also somewhat variable. We know under ideal circumstances with excellent training that lactational amenorrhea is very useful for 6 months. And in many settings, that is also consistent with cultural practices. However, what we also know, talking to women closely who report relying on lactational amenorrhea, is that they are not using that method in a way that is consistent enough to fully protect them against pregnancy. Certainly at the time of giving birth, that's an excellent time to use IUDs and implants. It really depends on how much contact with the healthcare system a woman is going to have on an ongoing basis. And I think inserting IUDs immediately postpartum is a valuable approach. However, we do know that there's still some controversy about the best insertion timing, and new data emerging all the time that the risk of perforation is somewhat greater in this early interval, and that the expulsion risk is, of course, greater at this early time. Nonetheless, I do think IUDs and implants are both excellent postpartum contraception, but the pill can also be excellent postpartum contraception. Now, when I was preparing this slide, it looked pretty good when I sat at my desk on the screen, and I realized in this room, it's impossible to read. So as soon as I sneeze, excuse me, I'll tell you what it says. And this comes from WHO's most recent medical eligibility criteria document. And even standing here in front of the little screen, I need my glasses to see what it says. But basically, in the first 21 days after giving birth, women should not use the pill because of the high risk of venous thrombosis during the first few weeks. So initiating a combination hormonal contraceptive is not suitable in those first 3 weeks because of that risk. And the WHO in the second 3 weeks, up until 6 weeks, it's still a bit worrisome, but less so. And in the US, that really gets to the situation of whether we would provide the pill at the postpartum visit, which is 4 to 6 weeks postpartum. One of the difficulties here, and I don't know the situation in India at all, but in the US, many of the poorest women who need assistance the most are also unable to return for a postpartum visit. And so finding a method with early initiation is very useful. Certainly we can send them home from the hospital with an entire supply of birth control pills, and we give them a date when it would be suitable for them to start. Because if they're otherwise well, they don't need an additional examination or checkup before initiating it. And that's one way to make sure they have their supplies, but we'll start them at the right time. I think in recent years we appreciate better the importance of the risk of venous thrombosis. But this really applies specifically to women who are not lactating, and the advice is different for women who are lactating, And this is more controversial because it is based on very limited data. The other considerations have a lot of data, but what is the effect of taking hormonal contraception along with lactation is still controversial, and therefore this recommendation is, I believe, very conservative. It's based on low-level evidence. Lactation is very important, and the proponents of lactation continue to worry that there might be an adverse effect. And so for lactating women, there is a recommendation not to start with hormonal contraception until 6 months. Now, my personal opinion in the absence of data is that we really need to weigh the potential benefits for that particular woman. And again, it depends on how much contact the woman will have with the healthcare system. Certainly in the United States, many women might initiate breastfeeding, and they will say they intend to continue for 6 months, but women don't actually know in advance for sure how long they're going to lactate, and we have a very high prevalence of early discontinuation of lactation. And we don't want to leave women in a position where they don't have any protection available at the time they discontinue lactation. But this is an area where, because of an absence of evidence, the recommendations are conservative. Anybody who has been in the room at WHO or also the US meetings, the CDC meetings, knows there's a lot of vigorous debate on trying to figure out what the best recommendation is. But this is where we are for the postpartum and lactation period. Now, finally, it is also of interest to think about women nearing the menopause and the use of the pill then. Certainly, most pregnancies that do occur near the time of menopause are typically unplanned, unwanted, and of course prone to a high risk of miscarriage. So in addition to contraception, though, the benefits of using birth control pills closer to the time of menopause will be a little bit in parallel to some of the benefits for the teenagers. It will reduce the anovulatory bleeding that is so common among women in this age group. Also reduce endometrial hyperplasia, and that is, at least in the United States where obesity is so prevalent, that is a particularly important benefit. It can reduce the onset of perimenopausal symptoms, and for this age group, the benefit with regard to ovarian and endometrial cancer is more salient and appreciated. Finally, there's substantial evidence that it will also help prevent the early onset of menopausal bone loss for the age group. So there are a lot of benefits to continue to use the pill in the perimenopausal years, but there really are also risks. And so it is it's a very individualized decision about whether this is the right way to proceed, and that's because in this age group, the baseline risk of cardiovascular events is much higher. There will be many women with hypertension, many women with diabetes, especially due to the increasing obesity in all countries. Obesity itself, which increases the risk of venous thrombosis. And also among women who smoke, they have at this point already been smoking for many years, most likely, and have the arterial damage that goes with it. Every one of those things makes the risk of using the pill an additional consideration in this age group. For the youngest women, these factors are not operating to the same degree, if at all, and we don't have to worry about the cardiovascular risks as much in young women. But certainly after age 35 and definitely into the 40s, we do have to really weigh these risks carefully. Now, this graph comes from a European study of VTE, of venous thrombosis, and it's looking at the joint effects of age and body mass index on the risk of venous thrombosis during pill use. Across the front, the bars represent age, less than 25 35, and then on the far right side, 40 plus. And going towards the back on the left side is increasing BMI. And so the very lowest risk of venous thrombosis is in young women of normal weight. And you can see that if either as age increases or BMI increases, the risk of venous thrombosis begins to increase as well. And in the back corner are the women who are over 40 with higher BMI, and you can see the dramatic absolute increase in VTE risk for these women. In my practice, those are women where I'm very unlikely to ever provide a combination oral contraceptive because I think these risks are substantial and worth discussing with patients. The medical eligibility criteria is organized such that it looks at each possible risk factor separately and gives a grade based on a separate risk factor. And as you know, their grading system goes from 1 to 4, where 1 is anybody can use the pill because the benefits always outweigh the risks, and 4 is pretty much nobody should use the pill, for instance, because the risks will outweigh the benefits. All of these individual factors are a category 2, like age greater than 40, obesity, even well-controlled hypertension, diabetes. Each one of those different risk factors is just a grade 2, which means benefits generally outweigh the risks. But what you can see in the fine print in the medical eligibility criteria is they don't know how to come up with a specific recommendation for a woman with multiple risk factors. You know, you can't take 2 and 2 and 2 and 2 and say it is still a 2 as a recommendation. And so I think that this is a very important thing, and it certainly leads me in my practice that if a woman is over age 40 and has additional risk factors for cardiovascular disease, that I will not recommend the pill. Now, if a woman is 40 and otherwise completely healthy without those risk factors, I think the pill is a fine idea, and it can provide her with all the benefits I discussed previously. Now, this particular figure is all of, I think it was 60,000 women in this study. It turns out if you take away women who have historical risk factors for VTE, of which the most important one is family history, all of these bars become much flatter. So the relationship stays the same, but the absolute risk is not as high as it was. And all that does is really emphasize for us the importance of taking a good history to identify that. And venous thrombosis is, of course, much more common than stroke and myocardial infarction. But after age 35, for instance, in smokers, we know that the risk of myocardial infarction goes up dramatically. It's still a much more rare disease, but these are the risks that we need to pay attention to, that in the younger age groups are not as relevant. So just to put it all together in my last 10 seconds of time here, I think we have 3 important age groups to help our decision making. For teenagers who are typically healthy, the pill is nearly always a benefit. Again, we're taking a history to identify whether there's a risk factor is the concern. And for births, we need to delay because of VTE, also delay because of lactation. And in the perimenopause, we need to weigh the individual risk factors for cardiovascular disease. Thank you.
Avion. Thank you, Dr. Carolyn. I think you sort of spoke on a subject of extreme importance to all of us, and also makes us realize that across the borders, whether it's the US or it's India, the concerns are absolutely the same. I almost never have a patient asking us how effective is this pill, what is the failure rate. The only question they ask us is, will I get cancer, will I put on weight, and will I be able to have a baby? So when I want to. So eventually the concerns are the same all over the world. And I think you have a huge amount of experience in the field, and it was wonderful to hear from you. Thank you so much.
In India, It's a big problem that below 20, I don't think the adolescents use the oral contraceptives at all. And if they use it very irregularly. And that is why, they are not convinced that they should take contraceptives, even though they indulge in sporadic sex. And that is why there are unplanned pregnancies, and we do have this problem. Rural areas as well as the urban areas, we have adolescent pregnancies, and the outcome of which is not very good, as everybody knows. So my request to everybody is focus on the teenagers, and pregnancies should be prevented. And oral contraceptives are not really popular in India in an adolescent age group. They will use condoms. So I don't know what is your experience. They go about using this?
Yes.
No.
Condoms are great. Have the green light? Can you hear me? Yes. The condoms are great, and we try to emphasize condom use as well in the United States, and they are popular among teenagers, and there's increased use at first sex. The pill use in the United States started out with really married women in their 30s. That's where pill use began, and it gradually moved to younger ages, and we really needed a kind of a confidentiality structure that made it easy for teenagers to use it. But the biggest use of the pill in the United States is among teens and young adults before their first birth. The age, when we first got the pill in the United States, age at first birth was about the same as it is in India now. Age at first birth in the United States is now about age 27, and the main method being used in the years before that is the pill. So I think we've just experienced a big culture change in this regard over the last 30 or 40 years. But yeah, teenagers are challenging for anybody.
Well, the contraceptives which, the oral contraceptives especially, which are being used are more so for the non-contraceptive benefits they're getting out of this. So we have got a lot of polycystic ovarian syndrome girls over here, adolescent girls, or maybe 20 plus. So oral contraceptives are being taken by them without any refusal for any length of time. And also in a perimenopausal woman, there are a lot of usage of the oral contraceptives. But the proper usage for contraception, that is again a query that remains. Young people, if you ask about the contraceptive, they will talk about the emergency contraception more than if you say contraception, they will understand emergency contraception, because government has promoted that like anything on the television and media, which the oral contraceptives as contraceptives have not been promoted. So that's a big issue till now. However, now government has is in the back foot. So let us see what happens now.
I think, Ratna, what you said was that use of oral pills by the teenager is not much, because I think we are not making them aware. There is a cultural problem with us that in front of parents or other people, it is not very nice to talk about it, not very nice to talk under the TVs, on the media, and other places. So in fact, we are not encouraging, because people think in the society that if you encourage the use of the oral pills and other things, we are encouraging sex and other things. So because of that, I think there's a hindrance that we are not doing, but it becomes our, as a practicing gynecologist, becomes our duty. When we meet these young girls, when they come with problems, I think quietly, confidentially, we can talk to them and explain to them that using oral pills would be much safer than depending on the condoms and other things which they can, otherwise they are using the emergency pill, as Dr. Ratna said, and which was causing all sort of irregular periods and other problems for them. So I think culturally we have to now come out and explain to them that use of oral pills would be safer, preferable, and it should not be avoided, because there won't be any weight gain or other problems with them.
I do think one of the challenges is that we all remain uncomfortable talking about sexual matters, even though it should belong to us as gynecologists to do this. And what I tell my colleagues in the United States, and I think everybody who's a parent understands this completely, you cannot teach your children good manners by telling them please and thank you once, or telling them to do their homework once. We have to talk about it over and over and over again as our children are growing up, and I think the same thing will be true about sex education. One of the lowest teen pregnancy rates in the world is in the Netherlands, where everybody sees a GP, and as soon as a girl is a teenager, the GP will say automatically to the teenager, so when are you going to start the pill? They have one of the highest pill use rates in the world. They started early. It is considered normal course there, and they also have the lowest teen pregnancy rate. So they're an example for all of us.
First, I would like to congratulate Walter Bushnell for bringing this most important topic of contraception, because it will be the need of the world. The world resources are getting scanty and the population is increasing. And 1 billion, it took thousands of years to become 1 billion. Within 40 years, it became 2 billion. Within 30 years, it became 3 billion. And if this progresses more, I don't think we are going to save our children any resources to live on. So thank you very much for bringing this important topic. And I congratulate Dr. Caroline for sharing her experience with us. Each and every method of contraception has a place in the program. And it is the selection of the candidate that is important for the success of the method. In a country like India, a long-term method is very necessary because young couples produce children. And by the time they are 20, they'll be having 2 kids. So that some long-term method, I would like to also mention about tubectomy, the vasectomy, or a long-acting IUCDs would also be more suitable for our country. And we gynecologists should leave this hall with one conviction, that you would like to practice laparoscopy, you would like to do IVF, you would enjoy doing these super methods of present treatment for women. But also keep in mind, a woman's health is spoiled by every pregnancy. If you can control the pregnancies, it will be the best basic way of improving the health of the women. Thank you.
Madam, can I just ask you one question? It's a disruptive question because things have changed a lot. In our country, if you give regular contraception to teenagers, because the country is in a cusp, there's a lot of controversies going on. It may be that, you're very permissive, you're trying to make them have sex. So what I feel that instead of having OC pill daily, look at another scenario. Nowadays, we can just have post-coital contraception. So you have sporadic sex, as she said. Many times they are not having regular sex. So if they have a sporadic sex, they have a post-coital contraception in the form of a pill. At the end of the month, if they miss their period, they do a pregnancy test. So you push for the pregnancy test as well. Push for the concept that if you miss your period and you have sporadic sex, you may be pregnant. And if you are pregnant, you just give them a abortion pill. So, here on one side, you have maybe 12 or 14 incidences of giving the pill in her whole reproductive lifetime, as compared to taking a OC pill daily for, say, 10 or 15 years of her life. We don't know the long term. So if you look at the two parts, which would be a better part to push?
This will only work if it's really infrequent. That is my answer to your...
Once they have children, then we go to the best, as far as I'm concerned, the best contraception after they have kids, because I come from a family planning family. My dad got Padma Shri in 1974 for family planning. He was from Harvard University. He was Dr. Sunawala's colleague. I have been grown in the field of family planning, though I don't practice it. But if you are, after your family is complete, the best way is to do IUCD, according to me. The temporary contraception, once you're married and you have a kid, that's the best way as far as I'm concerned. But for the young teenagers who have sporadic sex, in our country the sex is not, I don't know, we'll have to do a study on it, but I don't think they have regular sex. It's the sex is very sporadic, and for that kind of sporadic sex to push for a daily use of contraception, I don't think it would be appropriate.
You know, Rishikesh, I would just like to add a point. That I think education is something very important. So sexual education should be really pushed amongst all the teenagers, amongst the parents, as you, all the eminent people on the dais have said. Somebody mentioned about parental education, the sex education, like you said, in Netherlands, the parents just ask the young girl, have you started the pill? So the awareness of the little child and the one-to-one relation between a mother and a daughter is extremely important. And I think education, keeping in mind the sporadic nature of sexuality, which is happening once in a while, should be covered well. And I fully agree with you, Rishikesh, that you know, if you're constantly drugging yourself, may not be the right thing at a very young age. But they are the ones who get into real problems, and they may come to you with 8 months pregnancy in the womb, you know, which is not good.
Thank you, but ladies, we just have a time for one more query or one more question, as we have 3 more sessions. So just, this is the last one. Thank you.
I just want to highlight 2 things. One, when we have a woman in the outpatient after delivery, that is a postpartum counseling, it is really very difficult to counsel them with OCPs. They are able to use ormeloxifene, because that is a twice weekly dosage, an easier schedule, lesser bleeding, and it is safe in lactation also. So they are more ready to use, and twice daily pill than a daily OCP in our country, and ormeloxifene being our own manufacturing CDRI, long time, long experience. Even in the adolescent young girls, we are using to reduce menorrhagia, the ormeloxifene. It's very promising results, and that is one. Secondly, I would like to add that India, just being next to China as the diabetic, the newer coming diabetic capital, and a great amount of insulin resistance among women, and the onset of diabetes as early as the 20s, the OCP use really is a great health hazard in our country, because it also promotes the insulin resistance and the dyslipidemia, to which we are already susceptible. There is a slight cultural or a difference between America and in our country.
Thank you so much, and we thank Professor Dr. Caroline Westhoff for her informative presentation, and all the chairpersons for their inputs. Kindly be with us for a few more minutes, as I'm requesting Shri Nishant Barlia to kindly come on stage and present mementos to them as a token of our appreciation. We thank Professor Dr. Caroline Westhoff first, and we look forward, ma'am, for your oration lecture tomorrow. And all our honorable chairpersons, Dr. Rishma Pai, Dr. Anjali Tempe, Dr. Ratnabali Chakravarti, Dr. Chandravati, and Dr. R.P. Soonawala. Thank you so much once again for all your inputs. Thank you. And this is for the presenters who are making presentations today. Please don't be startled at the ugly sound of the hooter. It's just a humble indication of you to wind up. So thank you so much. And let me introduce the second session. The topic is high-risk pregnancy, managing smart. And for this, the chairpersons are Dr. Vinita Singh, Dr. Hrishikesh Pai, Dr. Mridubhashini Govindarajan, and Dr. Kamal Bakshi. I request all of you to kindly come on stage, all our chairpersons, for the second session of the evening. The topic, as I just mentioned, is high-risk pregnancy managing smart. Do we have all our chairpersons? Dr. Vinita Singh, Dr. Hrishikesh Pai, Dr. Mridubhashini Govindarajan, and Dr. Kamal Bakshi. Dr. Vinita Singh is the Assistant Professor, Department of Obs and Gynae, Nalanda Medical College, Patna, Consultant Obs and Gynae Care Hospital, Kadam Kuan, Patna. Currently, she is Vice President, Patna Obs and Gynae Society, Chairperson, Young Talent Promotion Committee, FOXY 1719, and recipient of Dr. M.G. Mishra Award in Boxcon 2004. She's been awarded George Mohani Award in 2012 at RCOG London. We have with us Dr. Hrishikesh Pai. He's the Medical Director, Bloom IVF Group, which runs 9 IVF centers all over India. He's President Secretary General of FOXY and a member board of directors, World Body of Infertility, namely International Federation of Fertility Societies. Dr. Pai has been the recipient of numerous awards such as the Rashtriya Ekta Award, Indian Medical Association, Best Doctor Award, Navashakti Newspaper Award, Jai Hind College Alumni Award, RK Trust Award, Medscape India National Award, Lions International Gold Award, Ferticon, and so on. Lifetime Achievement Award, Dr. Kanal Goyal National Indian Medical Association Award, amongst others. Is it okay? We are very resourceful. Doctor is saying, where did you get it from? Dr. Mridubhashini Govindarajan, she's here with us. She's Clinical Director, Women's Center and Hospitals Private Limited, Coimbatore. She's the recipient of many awards, namely Lifetime Achievement Award by the Tamil Nadu Dr. MGR Medical University, Chennai, 2012. Best Woman Entrepreneur Award, Coimbatore Management Association. She's the author of these several publications and organized first national workshop on colposcopy in India in 1991 and has organized numerous conferences including All India Congress of Obs and Gynae. We have Dr. Kamal Bakshi. She is a well-known figure in the medical fraternity. She's a former professor and head of Department of Obs and Gynae, AIIMS, New Delhi. She is the medical director of the Women Clinic, Emeritus Professor, National Academy of Medical Sciences, and she has many awards to her credit, like Dr. B.C. Roy National Award, Eminent Medical Teacher, Lifetime Achievement Award of FOXY, Woman of the Year 1998, given by ABI USA. The Gyneplastic Surgery Society of India conferred her with the title of a living legend, and in fact an award in the name of Professor Kamal Bakshi has been instituted for the pioneering work done by her in the field of fetal medicine. And now I'd like to invite on stage the speaker of this session, Dr. Jaideep Malhotra. The topic is high-risk pregnancy, managing smart. She's the managing director of Art Rainbow IVF Agra, consultant IVF specialist at Ludhiana, Jalandhar, Ambala, Gorakhpur, Gwalior, Delhi, Sirsa, Bhiwani, Bareilly, Allahabad, Varanasi, Hubli, Kathmandu, and Dhaka. She is the president-elect 2018 of FOXY, SAFOMS 2019 and 21, and ISPAT. Editor-in-Chief of SAFOMS and SAFOG Journal. She's also the recipient of many distinguished awards like Indumati Zaveri Award, Jagdishwari Mishra Award. She's been credited with producing firsts of UP, IVF birth, ICSI birth, IVF twins, ICSI twins, IVF triplets, TESSA, ICSI pregnancy, etc., and also credited for producing first 300 test tube babies of Nepal. Dr. Malhotra, to begin her session. Thank you.
Thank you very much, and a very good evening to all of you. At the outset, I'd like to thank the Berlia family for giving me this opportunity to speak to everyone. Before I begin, I salute to all the OBGYNs who are sitting here with folded hands, because you are the ones who really actually are demanding all kind of respect, because what all of you go through throughout the day, 24 hours, throughout the life, and delivering all those babies and mothers safely and with vigor, and devoting all your life for that, it really demands a big, big namaskar to each one of you. Because I don't know whether our patients or any one of us really realize what we go through throughout our lives. And that is why when I was making this presentation, these are the thoughts which came into my mind. Because we don't know which pregnancy is going to turn into a high-risk one and your life is going to go for a toss that particular day or that particular night. And that is important. And especially hats off to all those single women, with small nursing homes who are really managing all that show themselves, along with the administration. I'm sure all of us know the definition of high-risk pregnancy. And I really don't have to go into all the details. But yes, definitely wherever the mother or the fetus is at jeopardy or at risk, and a lot of consequences which can happen, as whatever was turned into a very normal delivery can take a twist within a few minutes, and the things move so fast that you really don't know what to do. And that's why probably a little anticipation, a little preparedness, and a little protocols into place, especially in managing high-risk pregnancies, is definitely going to take us a long way. Now, as I said, all pregnancies and all deliveries are potentially at high risk unless they prove otherwise. But we have to also understand that, yes, there are about 20 to 30% of the pregnancies where from the outset itself, you can say, yes, here the mother or the baby or the neonate is at an increased risk. And especially for improving the obstetric outcome, this group has to be identified. Very, very important. And a special help and a special treatment and a special care has to be extended. And even with all the special care you might extend, this is the group which is actually responsible for almost 70 to 80% of the adverse perinatal outcome. Now, when you go through all the maternal death analysis, you may see all these data coming from Africa, Asia, and Europe and the developed countries. But at large, there are few things which are common to all of them, whether it's hemorrhage, hypertensive disorders, sepsis, infection, and abortions. Now, what is common between all of them? We have to understand that though the major causes of maternal mortality have been bleeding, hypertensive disorders, eclampsia, puerperal sepsis, obstructed labor, and unsafe abortions, except hemorrhage, other causes of maternal mortality actually can be identified and treated effectively. So we really need to put certain facts in place, and that's important. Everyone goes through the definition of high-risk pregnancy factors. I'm not going to go into that. We know it all. We also know the high-risk labor. We also know that, yes, preterm labor, post-term, previous LSCS. Now, who is responsible for all those things, especially the previous LSCS? Again, we need to be really understanding. If we'll avoid the first cesarean, then only we will be actually making the next pregnancy safe. So there are certain points which I would definitely like to highlight again and again. Now, when we are looking at a patient comes to a clinic, how much time do we spend on taking the history? WHO says at least 46 minutes should be spent, and we give about 1.5 minutes. So how much history are we going to really delve into? Because once you're looking at screening for high-risk pregnancy, the aim is very clear. The aim is to actually improve the obstetric outcome, to identify the group and give that extra care which that group really requires. And definitely, if you identify them early, you will definitely be ready for all the complications. And that preparedness is very important for a good outcome as far as care is concerned. And avoidance and treatment of complications is also very important. Now, there is a whole list of risk factors assessment. Now, you could assess before the pregnancy, if possible. You could assess at the initial visit. You could assess all the trimesters when the patient comes, or it could happen even, during the delivery. Now, if you go on the net, we have a lot of tools which are available to us. I've just put in, you may not be able to read, but I'm just trying to tell you that the Ministry of Health has put in a lot of assessment tools. But how many of us have actually gone ahead and dug those out? Because they are not circulated apart from the public hospitals or the government doctors. So I think we have a lot of help available on the net. We should go and look at these tools and utilize as much as possible, because we're going to bear the consequences if something goes wrong and if you're not really prepared for it. Of course, there is a scope for preconception counseling and antenatal care, because antenatal care is the crux of all. If we are able to inculcate into our patients to come to us for at least what WHO suggests, 4 antenatal visits, we will be able to pick up a lot only if we are alert. So regular visits are very, very important. Accurate dating of gestation is very important. And to formulate a plan for continuing the obstetric care and delivery is again very important. And all these interventions will reduce the emergency interventions which may be required if. And that first visit is the most important of all. Because on that first visit, we are going to take a history. We are going to look at the past obstetric history, because only on history you will be able to detect almost about 15% of the patients. And also, if we take the history of life-threatening situations which actually happened in the past, those are also very important. Yesterday, I think Dr. Naren was delivering one patient in the middle of the night, and he comes back and he says that this was the second para. She delivered very nicely, but when she started bleeding at that point of time, the patient was telling the doctor, I had severe bleeding last time, and you had to give blood to me. And he is saying, why you didn't tell? If I would have told you, then you would have asked me to bring blood again. So they have very vague reasons for not divulging the history. So, but we need to really take it out and also tell them that yes, if you're going to tell us the truth, we are going to help you much better. Now, once you've done with the history, then there are certain things where prediction is very easy. So we should be really looking at and ensuring that the things which we can actually predict, we should spend a little time. And one of them is preeclampsia. Now, preeclampsia affects almost 2% of all pregnancies and is a major cause of maternal and perinatal morbidity and mortality. At the first visit, especially a woman who will come who's at a risk of preeclampsia, she should actually be evaluated. And there are a lot of series of characteristics which you can look into, especially her age, her body mass index, and previous family history of preeclampsia. All those are important as far as history is concerned. And we are very fond of doing ultrasound. And today, in all the fetal medicine workshops and all, we are concentrating on 11 to 14 week scan, a must. Now, 11 to 14 week scan, a must to rule out. One important thing which we say is, yes, nuchal translucency and aneuploidies, which are very important. But during that period, there are a lot of other things which we can do, which will predict a lot of things later on. And if we utilize that particular time, and if we look at the uterine artery pulsatility index, if we look at the mean arterial pressure, if you see here, both of them are raised in early preeclampsia. And if you look at the PIGF, which is reduced, we are going to pick up or predict preeclampsia in a number of patients. Now, along with that, I will go a little further and will say that if you have picked up somebody who that is probably a candidate for preeclampsia, we can very easily put them on low-dose aspirin therapy. At least that preventive aspect you can look into, especially by the time she will actually come with a little high blood pressure, it will be much later. And if you are able to start aspirin at 16 weeks, you will be able to do much good to this patient and prevent a lot of other problems which might come up a little later in pregnancy. Similarly, I would go a little further ahead and say that in that 11 to 14 week scan, please measure the cervical length. Because at any point of time, if the cervical length is less than 25 millimeters, her chances of having preterm delivery are much higher. So what extra time am I spending? Not much. And what this particular intervention is going to take me a lot further, because again, India is the biggest contributor of world prematurity burden. And we don't have the infrastructure to support all those premature babies which are being born. So that's again very important aspect, and we can really easily, based on the history, based on the characteristics, if you add on to the cervical length, you can easily go ahead. And even today, FIGO has come out with a white paper, and FIGO says that if you see a short cervical length, please treat these patients with progesterone, which is very inexpensive and easy and has no adverse effects and will definitely reduce the recurrent preterm birth. So these are the interventions which would definitely help as far as high-risk pregnancy is concerned. And you can easily see as the cervical length is shortened, the probability of preterm definitely goes up. And these are very nice pictures, very easily detectable, and prophylactic circulates and other things can also be taken up. And I don't think if you really have fibronectin available, you may go ahead and do the fibronectin, but otherwise this is more than enough. Somebody was just talking about India is the diabetic capital of the world. And we have loads and loads of gestational diabetes in our pregnancies as we go by. And the load is so much that it accounts for almost 85% of the global deliveries in the low, middle, and upper income groups, countries. 90% of the maternal and the perinatal deaths and poor pregnancy outcomes, and 80% of the global diabetes burden is only in this region. And hyperglycemia as such per se in pregnancy contributes to obstructed labor, preeclampsia, postpartum hemorrhage, preterm delivery, neonatal asphyxia, birth injuries, and so on. And majority of the women are not screened. Even in spite of our own universal screening by DIPSI, which is very, very simple, can easily be done, we still don't do that. And once you do that, a little bit of advice and medication is going to take care of a lot of other issues. I remember, Abha is here. This must be about 15 years back. I'm actually privileged because I was very strong in ultrasound, and this was an IVF pregnancy very early in my IVF career, where I detected placenta accreta. I think you'll remember this case. And once I detected placenta accreta, I could not sleep because here was a 31-year-old girl who had conceived almost after about 10 years, and I see a placenta accreta, and in a small town like Agra, where only at that point of time there were 1 or 2 blood banks, which were also not very adequately furnished. So I called her up and I said, Abha, will you help me? There is a placenta accreta. She said, oh, please send. We have, all the techniques. They had uterine artery embolization. We will keep her. So she stayed in Delhi for quite a few weeks before she delivered. And the day they posted her in the morning for a cesarean section, in the night she started bleeding. And the whole team of Gangaram Hospital, 80 units of blood, and I don't know, that's what I remember. But we were able to save that girl and also the baby. Anticipation is important. And with anticipation, also referral to the place, because I don't have to be happy that it is my IVF pregnancy I have to deliver. What I want is that the baby and the mother have to be well. And that's where we have to take the right decision at the right time, and that's important for us, because I'm sure everyone can detect. So anticipation and preparedness is very important. And once you have detected placenta accreta, definitely the management should be offered. After 34 weeks, the patient has to be inpatient, and you have to be prepared with all that you can do, because this is one explosive period which is really going to take a toll on everybody. Now, antenatal care is very important, but the quality of antenatal care is also important. How are we providing the care? What is the infrastructure available to us? What are the human resources, the knowledge, the skill, and the capacity to deal with it? It's not only yours, your team, your paramedical staff, your anesthetist. How prompt are you able to deal with the complications is also important, because when it comes to life-saving, these interventions are which are very, very important. And improving the quality of care. The health facilities are always put to a test, because how you are going to really behave in that golden, let's say, a few minutes is very, very important, because then only that important focus of preventing mortality can be taken care of. So we must encourage women to seek skilled care at childbirth. That only can reduce the stillbirths and the complications. And also we have to help women get care on all the other aspects which may be there. So quality of care is very important. And as I said, WHO says a minimum of 4 antenatal visits. Not all our women are that privileged. And when I talk about the private sector, I'm sure all of them come every month. But the other sector definitely is not so lucky enough, but that's important. And if all of us talk the same language, then only the impact will come. And that is what I am actually, my main purpose of my talk is that all of us have to talk the same language. And the moment we do that, if you'll see the number of antenatal visits, if they are more than 3, the institutional deliveries rise. And if the institutional deliveries will rise, there will be an important impact on the maternal mortality, which comes down in a linear way, and also neonatal mortality. And that is what we are looking at. Now, we are using, I would say sometimes misusing ultrasound. When I say misusing ultrasound, I'm not talking about sex determination, but I'm talking about that every time a patient comes, we are doing ultrasound. Maybe that's not really required. You must know what are the optimum number of scans which are required. According to our Ministry of Health and Family Welfare guidelines, only 1 is important, because when governments make certain criteria, they have to look at a larger picture. So 1 scan at 18 to 19 or 18 to 20 weeks is what they recommend. But yes, if it is feasible, you could do an early scan. 11 to 14 weeks is very, very important. And if required, another scan at 32 weeks. And if it is a high-risk case, maybe if you have to do a color Doppler, you may have to do it every week also, or every second day also, when crucial decisions have to be taken. And as I said, once you're doing a first trimester scan, maternal age, nuchal translucency, a little biochemical test, uterine artery pulsatility index, mean arterial pressure, and cervical length is the bare minimum you should look into. And this will give a lot of insight into management. Now, those of us who are lucky, who can do the color Doppler, if you're looking at using Doppler, especially in high-risk pregnancies, there is a definite reduction in the perinatal deaths. There's definite reduction in induction of labor. There are fewer admissions to the hospital. No report of any adverse effect is there, and there's definitely no difference as far as the fetal distress in labor is concerned, and no difference in the cesarean delivery rate. But yes, we are looking at the perinatal deaths, which is very important. And very crucial decisions can be taken if you are looking into how hypoxemia is getting into acidemia, and that crucial few hours are very important for the decision making, because those are the ones, if we have not taken a timely intervention, we will either lose one of the two. Now, along with this, what we normally do on a visit, as far as assessment is concerned, a little bit of advice about diet, nutrition, and other things is also very important, and we should spend a few minutes. Because when we are looking at outcome, a good diet, a de-stressed atmosphere, and freedom from many kinds of infections, especially wherever immunization is possible, if that can be taken care of, all those will really add on value to what we have not been able to achieve till now. Now, all high-risk cases should be managed as per standard guidelines. But where are the guidelines? We don't have guidelines as far as FOXI is concerned on high-risk pregnancy. I think we should be making one. But yes, the Ministry of Health has a lot of papers which we could utilize and we should be looking at. Are we looking at the warning signs for obstetric emergencies, which are really important, which can be identified? All the high-risk cases should deliver at the institution, and a timely referral is very important. And if you look at this, risk of the level of pregnancy, this is Malaysian government, which has given a white, green, yellow, and a red circle to the patient depending upon the kind of risk that patient carries, and also then they are treated accordingly. All the red ones are actually treated, they are given urgent medical attention and are in a tertiary care hospital delivered. Similarly, small for gestation, again very important. 3 to 10% of the pregnancies have small for gestation babies, and in our country, most of them are small for gestation. The overall birth weight of our children is much lesser, and they account for almost 20% of the stillborns which are there. So we are really looking at that. Again, intervention for them is important. And I would not say during pregnancy, pre-pregnancy counseling and also nutrition and certain criteria are also very important. But if it happens during the pregnancy, very time-tested drug, my mother-in-law used to use it very often, allyl estradiol in fetal growth retardation, and has been giving very good results, and we could look into. Now, aims of antepartum fetal surveillance, again, are very clear. Prevent fetal demise, prevent fetal hypoxia, determine the optimal time for delivery, and determine the optimum appropriate mode of delivery. So you must be looking into fetal monitoring. A lot of us depend on the CTG, but CTG only is at the last few days where will show you abnormality. But if you're looking at color Doppler, a lot of sequential changes will give you a lot of warning signs before. And that's why probably color Doppler is one which is very, very important and should be used, because the action points are very clearly defined. As soon as you see redistribution, as soon as you see that there's altered blood flow to the system, you have to take a decision as far as delivery is concerned. So a balancing act between the intervention and succumbing the baby to hypoxia and demise are important. And that's why that time of delivery is very important, because if we are not looking at that time of delivery, the road to death is very much destined. And if you see here, I don't have time to go into the details of how the color Doppler changes can be actually looked into, but I'd like to show you here and see. First you'll see is abnormal fetal growth, then you'll see the abnormal arterial Doppler, then you look at the abnormal venous Doppler. Now, in between, there is a time frame of almost 2 weeks. And from abnormal venous Doppler to abnormal CTG, another 2 or 3 days. And once abnormal CTG is there, you need to take the baby out, definitely. So, very high quality interventions related to maternal and child health services. Actually, if you are looking at those, it is really very much possible to achieve a lot of objectives which are very far-reaching as far as our health and economic conditions are concerned. So when to deliver is a big question which really needs to be addressed, and that's important, and that's the human right of that particular woman. She demands that she has to get a good place to deliver, and that's important and that's achievable. But where to deliver is also important, because if she is high-risk pregnancy, then definitely a critical care unit is where she should be delivering, a tertiary care unit is where she should be delivering. We need to set the standards high for those, and I know that FOXI has been doing a lot of these critical care conferences. Rishma has done a few, Alpesh is doing a lot, and so we are looking at that. We need to define the protocols for intrapartum care. We need to define the protocols for fetal monitoring. We need to understand when to refer and where to refer Where to refer is also very important. Birth preparedness and complication readiness is very important, and counseling for that should start right from the beginning. We have all identified the gaps. The 3 delay model is age old, but what have we done for those? And we can do a lot at our own also. We don't have to look at the government. Obstetric helpline is something which will really work. A referral chain is very important. When should you send, where should you send, what should be the referral note, what are the main salient things about the history which should be there, what advice I have to give to the family member. Because normally what we do is, if something is going wrong, we pack the patient in the ambulance and we say, Bhaiya, bade kisi hospital mein le jao. And that is the worst you can do. You have to counsel the patient why you're doing it. You have to refer in time so that wherever you're sending also, the person is able to, provide the best possible care. The referral strategies have to be in place. The means of transportation is very important, and there are a lot of unique ideas. And this NASG government, this is very, very important, where especially when the patient is bleeding and may go into shock, this is something which is life-saving, because those crucial 3-4 hours of transport are very important. We have mobile, these motorbike ambulances where somebody, paramedical staff with emergency drugs, goes and, looks after the patient, gets her ready till the ambulance arrives, because those few minutes are very important. And networking of the primary, secondary, and the tertiary care centers are important. So all this can be these initiatives are very much achievable if we look into the right direction. And as I said, the Ministry of Family and Health, Family Welfare has given a lot of initiatives on high-risk pregnancy. You can go on the website and download all these guidelines, which are very much there. And I'd like to stay here. A stitch in time will save 9. And there are a lot of interventions which could actually mean a life or 2. Maxsulf for seizure prophylaxis and neuroprotection. Steroids for preterm. Prophylactic anti-D, tranexamic acid pre-surgery for PPH reduction, prophylactic bracing sutures, prophylactic progesterone for prevention of preterm delivery, prophylactic cerclage for multiple pregnancies and short cervix, anemia correction, and so on. So all these can be looked into. And this is one of the latest papers which I was very lucky to be part of this study, which has just come in the Lancet in this year, April itself, where 1 gram of IV tranexamic acid will actually reduce bleeding by 30%. And this has really become a big, big thing now, because that 30% can take care of a lot of patients. And if you see here, this study was actually done in 20 countries and almost in 191 centers. And as I said, FIGO is also recommending all these things, Maxsulf and all, which I have already talked about. So all these small initiatives, if we'll take, if we have a PPH box ready, which Foxy has prepared, Sheila Mane has done a lot of work. A balloon tamponade, you don't need a Bakri balloon. You can just make a condom balloon yourself. Bracing sutures should be taught to every postgraduate. And if required, embolization in all the tertiary care centers will. All these emergency procedures will definitely reduce our maternal mortality for all these things. And lastly, I would say, we have done it in Agra, Emergency Action Squad. If you are in trouble, just ring up. Call your friends. Do not hesitate. And you will be able to, take care of them. Not only as far as patient care is concerned, your morale boosting is concerned, but also if there is any mob value, which also can be taken care of. And as I said, Foxy has taken multiple initiatives. EMOC is one major project which Foxy has taken. We are training, medical officers we are also making mother and baby friendly birthing facilities. And there are a lot of other proposed actions which we are doing. And we have collaborated very extensively with the Pradhan Mantri Surakshit Matritva Yojana and a lot other things which we have been doing. So I would say sky is the limit to what you can do. But I'm sure all of us know a lot. But knowing is not really enough. We must apply. And willing is not enough. We must do it. And once we do, then only we'll be able to, bring about what change we are really expecting in our management of high-risk pregnancy. And anticipation is very, very important. I'd like to thank all of you for giving me this opportunity. And I would say I don't want to get to the end of my life and find that I have just lived the length of it. I want to have lived width of it as well. Thank you so much.
Very good evening to all of you. At the very outset, I would like to thank Walter Bushnell Pharma Company for choosing such an important topic. As we all know that each and every obstetrician and gynecologist, we are trying our best to reduce maternal mortality rate and neonatal mortality rate. And even the whole India Prime Minister, he is more interested on this, and there is so much of program is going on, Surakshit Matritva Yojana and so on. So we all know that if we act smart, and we start taking care from preconceptional group, and we counsel them, taking care in antenatal period, we can seclude the high-risk group, act smartly, then we can reduce maternal mortality rate. So I must congratulate Madam for giving such a wonderful and very informative talk regarding this. Thank you, Madam.
First of all, congratulations for the Berlia family. I think the hall is so full that you will not find it in the majority of conference, and that speaks something about the value of this conference. And second, congratulations, Jaideep, for trying to summarize half of the textbooks of obstetrics in 20 minutes.
That's the hardest one.
You've done a very good job of it, and I think you've put in very nice perspective about what an obstetrician can do and should be doing, which is identifying the high-risk patient and then preparing them mentally and physically, following them up properly, and being prepared for emergencies, and which category you're going to be prepared for emergencies. I think it's a wonderful talk. But I think the only couple of things that I would like to add is we have to understand that we have deficiencies as well, and we have a lot of deficiencies. Our maternal mortality and neonatal mortality in India is far higher than Sri Lanka and Bangladesh and a lot of other countries which are poorer than us. So it's not just the poverty, it's the mindset as well. And I think we have to work towards changing that mindset. And I think maybe educationalists like Dr. Kamal Bakshi can contribute also, because we don't have a specialty called maternal fetal medicine in India. I think maternal fetal medicine in India, the training programs are crucial, and they have to be done by all of the educational institutions. It's a super specialty or a subspecialty of qualified obstetricians, where all of these things that Jaideep mentioned are put together, the intensive care units, the intensive care for a sick mother, the neonatal intensive care, and a lot of, the fetal medicine part of it, following the baby in utero part of it, all of that can be put together by dedicated specialists in this field. And I think that's a very crying necessity today in this country. And also maybe midwiferys. Thank you.
I would first of all congratulate the Walter Bushnell family. I was amazed at the ethics, the quality, be as far as the education is concerned, be as far as the company. I mean, they are sponsoring projects, research. Very few people do it. And without science, without research, the human beings cannot have a better quality. Thank you for that lovely quality and where we exist today. And your products are mostly women-friendly, and they are of great use. Even Urispas, you take each one of them, is excellent. I would say, I don't know, it's a vast subject, and you covered so beautifully. But as far as when I traveled, as far as Sri Lanka is concerned, Bhutan is concerned, look at their mortality has come down. Why? Because they are committed. They carry out. They just don't talk. They implement decisions and taking into action. When they have a PPH, they have the men. They have given them the bikes that go and save and get that patients. Secondly, the countries do not have thalassemia. And I'm surprised when I was talking to a patient yesterday. What is thalassemia? And we still have thalassemia in a country. We should not have even a single thalassemic patient. That is why, that means before a patient comes, pre-pregnancy counseling. I agree, every pregnancy is very high risk. There is a vast load, but we need to decentralize. We should have few obstetricians who must look after the repeated pregnancy loss. Then they'll think right and hit the nail and see where the fault lies. When we were students and now where we are, diabetes has increased tremendously. And we have to think of diabetes. We have to think of hypertension. Thyroid, we are an epidemic, so we must not let thyroid be there. So what I mean to say, each one can take either endocrine, hypertensive, diabetic, various APLA, the number of patients we are getting who have repeated losses, deep venous thrombosis. Then not only that, after delivering, we forget. We don't realize that this very patient later can get diabetes. Follow-up is very important. And very beautifully, we started the seminar, Oral Contraceptives Save Pregnancy. In the pregnancy, the seeds of adult, what we are and what diseases, all these seeds are during pregnancy. So the pregnant women needs to be looked after by the obstetrician, by the husband, by the society, so that when the newborn is there, it is detected right from the first trimester what the patient is going to have. So with these words, since the time is short, I would say I would like to thank everybody for the excellent knowledge and the team spirit, and especially Jaideep, you have done a wonderful job. And Doctor, you have said really right that we need to be committed. Thanks to
So
everybody.
I think I will summarize. Jaideep, of course, is our incoming president, and I wish that, I am now Secretary General for the last 3 years. I wish I could have been also her Secretary General.
I would have loved to.
So primarily when I entered, medicine and I finished my OBGYN, I didn't want to do delivery. So I started doing IVF. And, over the last 9 years, I also had a second hat of being the Foxy. I started with the treasurer of Foxy, then I became the Deputy Secretary General and the Secretary General. And I also got exposed a lot to the, social obstetrics part of our profession. And what I find that is that there is a trend for majority of you to shift over to the IVF part. I was called on the ICMR board just about 3 weeks back, and they were presenting in the ICMR, and they said there are already 2,000 IVF centers registered. So there is a tendency, but what I realized, because my transition has been from IVF to obstetrics, I was telling Rishma, after I finish this Secretary General's post in the next 2 months, I am going to go back to obstetrics, because the actual satisfaction and to talk in present-day language, the actual money is not in IVF, but it is in obstetrics. And you please have to understand that. The second thing I want to make a point is that the Federation has about to launch the Manyata program, which is the biggest program which we are entering. It is a MacArthur Foundation, MSD for Mothers, and Bill Gates Foundation funded program with Foxy as a partner, and all the presidents, the present President Dr. Rishma, the next President Dr. Jaideep, and all the presidents, is going to be a long-term program where we are upgrading the nursing homes in the country. We are planning to upgrade 20,000 nursing homes. This Manyata program, we will have a Manyata Foxy certificate program. It has got 16 standards, and so the team, if you enroll in this program, the team will come and train you in those standards. They will look at your nursing home, they'll suggest, and you have to undergo a training program. At the end of the training program, you will be given an exam, and after the exam, you will get the certificate. Simultaneously, in the press, there will be a massive marketing. It's going to be like the NABH. We will be marketing the Foxy Manyata certificate program on a massive scale in the Indian press. So patients will go to the Manyata certified nursing home. So it's very important. Already 120 nursing homes have been enrolled, and the plan is to escalate the program to nearly 20,000 nursing homes all over India. So when you have these 16 standards that will be incorporated in your nursing home, automatically you will upgrade your services, automatically you will be able to take care of all emergency care, etc., and that will contribute to decrease in the maternal mortality in this country. So anyway, these are some of the programs that are going on, and I would like to thank, of course, Walter Bushnell because you have been always consistent in your calling us here and giving us a lot of respect. It's very important that you always respect us and give us a lot of love and affection. And before I end this program, I would like to respect all the seniors that are there. Dr. Sunawala, for example. Sir, you are a great man. And to be here, I really appreciate it. Because, you are a living legend. Dr. Chandravati is there here. Dr. Kamal Bakshi, all the past presidents of Foxy. Dr. Narendra Malhotra, again, I don't know, his energy is unlimited. I don't know where the energy comes from and till what time it will last. And Dr. Pratap Kumar, one of my friends and teachers, and so many big, and of course my better half, Dr. Ishma. I have to say that she's the Foxy president at present. One last point is that when she took over the Foxy president, she told me that my practice may go down because I'm going to I said, please concentrate on the federation. And 2 days back when we were seeing Modi and we were seeing his energy because he puts in a lot and we realized because when you are interested with a job, now you want to do maximum. And I can understand where Jaideep Malhotra is coming from because I know that she wants to put in her maximum work into her effort when she becomes the president of Foxy, because that's what leadership is all about. You need to sacrifice your life for performing very well. Anyway, thanks a lot for everything.
Well, as she aspires not only to live her life through its length, but also widthwise, Dr. Jaideep Malhotra's presentation also was a reflection of the same. She covered the entire length and breadth of the topic. And now, Mr. Nishant Barlia to present mementos to our speaker and all the chairpersons. Dr. Vinita Singh, Dr. Rishikesh Pai, Dr. Mridubhashini Govindarajan, and Dr. Kamal Bakshi. So there are 2 more sessions between you and the dinner. We move on to the 3rd session. Well, Dr. Jaideep Malhotra briefly touched upon the role of progesterone in her presentation, but talking on this topic in detail is our next speaker, Dr. Abha Majumdar. And the chairpersons for this session are Dr. Queen Aditya, Dr. Shivani Sachdev Gaur, Dr. J.B. Sharma, and Dr. Narendra Malhotra and Dr. Gauri Devi. I request all the chairpersons to kindly be seated, as now I have the pleasure to introduce all of them one by one. Dr. Queen Aditya is a consultant gynecologist at AMRI Hospital, Kolkata. Can we please have silence in the hall? Let's get to know our chairpersons a little better. Ruby General Hospital, Kolkata, and Papilio Clinic, Kasba, Kolkata. Her special interests are gynae endocrinology, vaginal surgeries, and high-risk obstetrics. We have with us on stage Dr. Shivani Sachdeva Gaur. She is the Director of SCI Healthcare, Secretary, Delhi State Chapter of ISAR. She has many special awards and recognition to her credit. Rashtra Gaurav Samman 2015 and Rashtra Ratan Samman from Women and Child Welfare, Government of New Delhi, and features in the Limca Book of Records for Surrogacy Public Awareness, are organized by Indian Society for Third-Party Assisted Reproduction. We have Dr. J.B. Sharma with us. He's presently Professor of Obs and Gynae, All India Medical Institute of Medical Sciences, New Delhi, and has over 300 publications in indexed and non-indexed journals. He's recipient of many awards and has prestigious awards to his credit, including Dr. B.C. Roy Award for Research in 2015, which was awarded by Honorable President of India. He also won Dr. Labsetwar Award of 2016 for research in genital TB. The next chairperson, Dr. Narendra Malhotra. He is Managing Director, Global Rainbow Healthcare Agra, and Director, Art Rainbow IVF Agra and Delhi. He's the President of ISPAT, President ISAR, Secretary General SAFOG, member FIGO Guidelines Committee. He has over 65 published and 300 presented papers, over 300 guest lectures given in India and abroad, and 25 orations. He is the editor of 18 books, many chapters, and on editorial board of many journals. We also have the pleasure of having Dr. Gauri Devi with us. She's the director, Gauri Hospitals and the Ridge IVF Group. She's the president-elect, Indian Fertility Society, ex-secretary general of Indian Fertility Society, executive AOGD, governing council, member executive board, NAR, CHI, DGES, ex-vice president of Menarche. She is a keen academician, has organized many conferences, and has been a speaker in many national and international conferences. And now I have the pleasure of introducing Dr. Abha Majumdar, our speaker for this session. She'll be talking on the role of progesterone in human reproduction, New Vistas. She's the director, Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi. She won the President's Medal for Best Medical Graduate in 1975, Dr. B.C. Roy's Award for Outstanding Contribution Towards Medicine in 1999, Vikas Ratan Award, Chitsa Ratan Award, Lifetime Medical Excellence Award, Abdul Kalam Golden Medal, Distinguished Teacher of Excellence Award for Postgraduate Medical Education, Rashtriya Gaurav Medal. I could go on, and I just hand over the mic to her. She's also member of editorial board of IVF Worldwide, peer reviewer of Journal of Human Reproductive Sciences, member of advisory board for Journal of Fertility Science and Research, and consultant advisor for queries to ndtv.com. Dr. Abha Majumdar.
Thank you very much for the kind introduction. Could I have the lights a little dimmed so that I don't see people who are walking around in the hall and talking in the back, please? It would give me a little bit of moral boost. And I would at the outset thank the family of Walter Bushnell, Jaideep, Barelia family for inviting me here. And when I was told to speak on progesterone, I thought, oh, this is the daily bread of mine. Every prescription has it. I know a lot about it. I thought when I have to put something together, let me read a little. I read a little, then I read a little more, and then I read a whole book. And that is when I could make this presentation. And I bring to you this presentation after doing all the reading and sort of learned so many things just because I was invited to give this presentation today. Now, we all understand that natural progesterone was first discovered in the world or isolated in 1930s. The half-life of this progesterone was very little, and hence it had a very low bioavailability. There was search for a preparation that could last longer and hence be used in human reproduction. Then came the 1960s. All the systemic progestogens were developed in the 1960s around. Well, they were very potent synthetic progestins, so potent that they could be used in reproductive medicine, but their main use came in oral contraceptives, where they could be used in very, very small doses. Yet, they were not fit to be used in gestations, and hence the 1980s saw further development of progesterone when progesterone was micronized. This natural progesterone, when micronized, could be given orally or by various routes. It efficiently was used in pregnancy-related conditions, and also in luteal phase defect in ART, because ART started developing at this time very fast. And now the new application of this drug is in PMS, mood changes, water retention. It is so good, it compares much, much better than the synthetic progestogens which are being used. The journey of progesterone through the world has been in the last almost 80 years. I told you in 1930, the first progesterone to be developed for human use was our age-old Proluton depot, which is 17-hydroxyprogesterone acetate or caproate. Then came the estranes, the pregnanes, and the gonanes. After that, in the same time, around the 1960s came the retroprogesterone, which was a progesterone which was very, very similar to natural progesterone, the dehydrogesterone or your popular Dufestone. And after that, in the 1980s was developed the natural micronized progesterone, which in France was marketed as Utrogestan in 1980s, and almost 20 years later, it was made in the US by the name of Prometrium. Two important differences. Just remember, progestogen is one word, and we break it into two. When we say progestogen, it has progesterone plus progestins, which are synthetic progestins, synthetic progesterone. So progesterone alone eases sleep, PMS issues, such as migraine, mood swings, no effect on breast cancer, heart disease, stroke. It is a mild diuretic, thus spares fluid retention, which progestogens do for PMS women. It has no effect on BP or carbohydrate metabolism, less potent, less active, better used by other routes than oral routes, whereas progestins, on the reverse, may actually exacerbate perimenopausal and PMS symptoms, mood swings, breast cancer, heart disease, stroke. They could also negatively affect carbohydrate metabolism, blood pressure, suppress the good cholesterol, and they are very potent orally. So these are the major differences why we had to leave the progestogens or the progestins and try to find a way to use natural progesterone. With this, I would bring one progestin, that is dehydrogesterone, which still has a place in human reproduction. And this is a synthetic isomer of progesterone. How is it made? It is used in pregnancy because it is very similar to progesterone in its immunomodulation effect. No other progestin has immunomodulation effect. Moreover, it is made by conversion with just ultraviolet light exposure of the progesterone molecule. So it is an exact isomer of progesterone known as retroprogesterone. It can be absorbed orally very well. 50% higher affinity to progesterone receptors than progesterone itself. It is widely available in Europe, UK, Australia, Hong Kong, and India. It was previously marketed in the US, but due to some political reasons, it is no longer available there. A word about oral natural progesterone. In the 1989s, a study evaluated that the combination process of two procedures, micronization and suspension in long-chain fatty acid, will make progesterone a stable compound. What did micronization mean? It meant a very, very small particle size. It refers to a particle as small as less than 10 microns. And 1 micron is 0.001 millimeter. So you know how small this particle is. They had to make such small particles to let progesterone be absorbed orally. And this study said that optimal preparation for administration of natural progesterone should include micronization and dissolution in oils like castor oil or linseed oil became the common oils in which it could be dissolved for use orally. So progesterone in human reproduction, well, we use it in luteal support, threatened abortion, recurrent abortion, and preterm labor. These are the 4 important uses in human reproduction of progesterone. Luteal support. We all understand that when do we require luteal support? It is required if there is luteal phase defect. And what is luteal phase defect? It is when luteal phase is unable to implant or maintain a pregnancy, but then luteal phase defect is sporadic, inconsistent, and elusive to diagnosis. So you cannot say that, yes, there is luteal phase defect in this cycle. It will always be there for this woman because it is sporadic. It originates from either pre-ovulatory events or post-ovulatory events. So we don't know from where it is originating, but then there is one universal fact that progesterone is the only drug which remodels the endometrium to support the luteal phase. Having said this, I would want you to know a little bit about progesterone and its immunomodulation effect. There is direct and indirect inhibition of T helper 1 cytokines. There are 3 important functions which progesterone does as immunomodulation. And to remind you, even dehydrogesterone does the same. It regulates HOXA10, so that there is NK cell recruitment and differentiation. 2, it regulates progesterone-induced blocking factor and thus Th2 cytokine production, which leads to inhibition of NK cell activity. So you don't need steroids or you don't need lipids or intralipids to reduce the NK cell activity. Progesterone does it very, very well, and compounds similar to progesterone would also do that. The trophoblast secretes the HLA gene. It causes HLA gene expression in the trophoblast, which again inhibits NK cell activity. So it's a very potent immunomodulator. Just progesterone alone can do everything what you want for a pregnancy to happen. So what is the incidence of LPD requiring luteal progesterone support? Natural cycle LPD is just about 3 to 20% in infertile women. It rises a little when there is a woman who has RPL or recurrent pregnancy losses. Well, in stimulated non-IVF cycle, you're just giving ovulation induction for probably 1 or 2 follicles to mature or for IUI. 50% of these cases would have LPD. And when you give heavy stimulation and you use analogs, GnRH analogs like antagonist or agonist, almost all cycles will have LPD. All will require luteal support. And HRT cycles, frozen embryo transfer, definitely require HRT. There is no doubt about it. Having said this, what do we use for LPD? Well, micronized progesterone, routes and doses in recurrent abortion. Oral tablets, 100 to 400 milligram, 3 times a day. Extreme variability in serum concentration due to individual gastric filling and enterohepatic circulation with too many side effects. So we do not recommend the use of oral micronized tablets. Then comes the intramuscular injection. It is again progesterone once a day in sesame oil and 10% weight by volume benzyl alcohol as preservative. Very painful, leads to abscess, sterile abscesses or otherwise. Warming the oil solution might decrease its viscosity and reduce the pain. On the contrary, what we say is put a cold pack. So remember, this is also now out of circulation. Very few centers in the world use injectables. Then comes the vaginal soft gel capsules, which are just 200 to 400 milligram tablets, very easily given in OD or twice a day doses, absorbed by first uterine pass effect, 10 times higher concentration in uterus compared to the serum or circulation, whereas intramuscular injection would have a very high serum concentration, a lower uterine concentration. We are here only concerned about the uterine concentration. How does it go to the uterus? We're putting the tablet into the vagina. Well, there is direct diffusion from cell to cell. There are lymphatics all around the vagina going right up to the uterus. It goes through them. And a vein to artery portal system exists in this area from where these drugs can diffuse and go to the uterus as first pass without having to go to the liver, without having to make metabolites, which cause all the side effects of oral progesterone. Then the gels. Vaginal gels are becoming very popular. Mostly in the West, people are shifting from tablets to gel. The advantage is gel spreads all over the vaginal epithelium, and hence absorption is better. Tablet sticks to one place. Don't let the woman sleep after she puts in the tablet. Let her walk around so the tablet moves around and has a bigger area to be absorbed. Well, this is a polycarbophil base. Please look into the product when you're using it. It should have a base which will stick to the epithelium of the vagina, and the emulsion is a oil and water suspension. From oil, the medicine will go to water, and then it will get absorbed into the vaginal epithelium. And this is the way this drug acts. These two are the ones which are most recommended for luteal support. Please excuse the wrong word written over there, recurrent abortion. This is all for luteal support. Well, one word about the oral natural micronized progesterone. This is coming up. We still don't have studies. We don't have randomized controlled trials for it. These are company-promoted, multi-centric studies where they've got the drug approved because the studies said that they were good drugs and they could be used in an OD convenient dose, and hence the companies have started marketing the oral OD dosage. It has a novel drug delivery system which causes sustained release of an oral tablet. Now here also, like in oral normal natural micronized progesterone, only 33% is absorbed, or there is just 33% of serum level, but that is only for 4 hours. This is for 24 hours. So one tablet stays there to give a progesterone concentration of 24 hours by gradual release from the intestine. Well, there is further advancement of this technology, and different methods are being used to optimize oral use. This is matrix sustained release technology. Advantages are smooth release of progesterone from intestine over 24 hours. Therefore, OD convenience is there. It avoids sudden drug release or dose dumping, thus loss of drug due to hepatic metabolism, and minimizes dose-related central side effects, such as sedation. ICAT is another technology where the micronized progesterone has two important qualities. There is a sudden release and a delayed release. So immediately blood levels are formed, and then there is a sustained level for 24 hours. This is a technology which probably Walter Bushnell is bringing about and would want us to see how effective this tablet is. Then comes threatened abortion. Well, we all understand, when do we say that my patient is threatening to abort? One episode of bleeding, spotting, and you say she's threatening to abort. She might come with a little pain and you could just discard her off that, no, nothing to worry, all looks all right. Well, statistics say that almost 10% abort if bleeding happens around 6 to 7 weeks after appearance of fetal heart, but just about 1 to 2% abort if bleeding happens later. That means by 10 to 14 weeks. So we all have to understand that if one episode of bleeding means 10% approximately will abort, well, there was at one time in the 1990s, we thought that serum progesterone estimation will tell us which pregnancy will continue, which will not. A single P4 of 25 nanogram was thought significant, then 14 nanogram, less than 14 was thought will lead to a fetal demise and loss of pregnancy, more than 14 will be all right. Then they found that 12 nanograms would be good. Less than 12 would be pregnancies are mostly doomed. And the lowest pregnancy reported in literature was with a 5.1 nanogram. So why was this so? We found out that there were pitfalls of using serum progesterone as a predictive marker of miscarriage and determining the need of progesterone supplementation. Why? Because progesterone has a pulsatile secretion with a 10-fold difference in its nadir and peak. Deficiency of progesterone receptors may lead to insufficient histology in the presence of normal progesterone levels. Lack of HCG stimulus, again, would lead to low progesterone production, and low hormones could be the result rather than cause of a failing pregnancy. So these were the pitfalls of using progesterone. So in this century, we sort of abandoned using progesterone as a marker for threatened abortion. Diagnosis and treatment of threatened abortion with exogenous progesterone should be empirical rather than that based on any progesterone levels. Treatment guidelines with progesterone supplementation in threatened miscarriage are just two. Dehydrogesterone is supported by evidence. Micronized natural progesterone is supported by evidence. And what is not supported? I was surprised to find this in literature. 17-hydroxyprogesterone acetate or caproate is not supported for use in the first trimester as a prevention of threatened miscarriage, and that is because it may increase uterine contractions and promote expulsion of the fetus in the first trimester. However, it is difficult to give recommendations as there is no accurate diagnosis of P4 deficiency. Then comes unexplained recurrent miscarriage. What is unexplained recurrent pregnancy loss in today's world? 3 consecutive pregnancy losses prior to 20 weeks? Maybe yes. 1 to 2% of women affected? Well, risk of subsequent miscarriages is similar with 2 versus 3 miscarriages, and therefore today most experts agree on evaluation for recurrent miscarriage after 2 losses. After evaluation, we still find almost 50% of cases which fall into the category of unexplained recurrent miscarriage. The uterine cavity is normal, the thrombophilia profile or APLA is normal, the karyotype is normal, the hormones are normal, the diabetes profile is normal, everything is normal, yet in such cases, progesterone has shown to be beneficial in decreasing miscarriage rate. Patients and physicians can be encouraged by the overall good prognosis, as even after 4 consecutive losses, a patient has had greater than 60% chance of carrying her next pregnancy to term. So don't lose heart, don't let your patient lose heart, because if you've not found a defect, probably progesterone might come to your and her rescue. Early pregnancy maintenance, we all understand progesterone helps promote trophoblast invasion and implantation. We all just spoke about the immunomodulation effect of progesterone for implantation, its HOXA10 activity, the HLA gene expression, the PIBF effect. There are other activities of progesterone. These are very important for uterine quiescence, especially in RPL cases, blocks PGF2 alpha, adrenergic receptors, suppresses contractile genes responsible for uterine contractility, decreases concentration of oxytocin receptors in myometrium, upregulates nitric oxide, which causes myometrial relaxation, and it blocks appearance of intracellular gap junctions. With all this, it leads to uterine quiescence, and it has been seen that if progesterone is given in the first trimester in RPL cases, Th1 to Th2 cytokine ratio is altered, favoring pregnancy. With this, Ari Kumarasamy in the BMJ in 2011 published results saying, right starting from 1950s to now 2005, every study favored the use of progesterone. Yet, what happened to PROMISE trial? This was a randomized trial of progesterone in women with recurrent miscarriage, and we were all awaiting its results last year. It was a multi-center, double-blind, placebo-controlled randomized trial with unexplained RPL. 36 countries in UK and 9 in Netherlands participated in this. Eventually, 836 patients completed the study. And what were their results? The important thing is that they used local micronized progesterone, 400 milligram twice, started it whenever the pregnancy test in urine was detected positive. That is as much as 6 weeks later than she was actually pregnant, and given till 12 weeks. They did not find an increase in live birth rate. So, what do we do now? Well, there were flaws with this study. Study was not adequately powered to include LPD cases. They missed out all LPD in this because they started after detection. May I take another 2-3 minutes? Chairpersons, can I take 3 minutes more? Okay. The study was not adequately powered to include all LPD cases because they did not start in the mid-luteal or early detection of pregnancy. Results were also confounded by a questionable strategy of P4 supplementation that is the same 6 weeks onwards when the background status on luteal phase deficiency was not clarified. However, the MHRA regulatory agencies said that progesterone and dufestrone, that means dehydrogesterone, both may have a beneficial effect in women who have had 3 consecutive unexplained recurrent pregnancy losses. With this, when do we supplement? The questions are still there for us to answer, and probably we'll need more studies for this. In the fertile window immediately after natural ovulation, or after confirmation of pregnancy by beta-HCG or UPT, after ovulation, say 2 to 4 weeks, or we use an algorithmic approach to identify LPD. I mean, you have to do something to say that progesterone levels, history, everything says it is LPD, so use it early. Why do we overprescribe? Every pregnancy is precious. What if an abortion happens? She has some crampy pain. There was a previous loss. That is a routine and fear of litigation. These are the reasons why we tend to overprescribe. Studies may or may not support. We need some TLC to be given to the patient, and maybe progesterone is one harmless TLC which can be given to patients. Yet, we do not know whether RPL unexplained will respond to this progesterone therapy or the confidence you institute in the patient by saying this is going to help. So the last is preterm labor, role of progesterone in prevention of preterm labor. These are the most important factors which help progesterone to prevent preterm labor. It reduces prostaglandin synthesis, oxytocin receptors, and thus decreases the gap junction and myometrial contractility. It also reduces cervical stromal degradation. It's a very important factor, and therefore it prevents ascending infection, the inflammatory response, and that also heralds preterm labor. Another important thing is it alters fetal endocrine-mediated effect, the signals which go to the mother's uterus to induce contractions, and increases PIBF. This is Optimum study, which was an updated systematic review and meta-analysis of RCTs. And what was the gist of this study? Vaginal progesterone decreases preterm birth in less than 34 weeks gestation in women with singleton pregnancy and a short cervical length of less than 25 mm without any deleterious effect on neurodevelopmental outcome of the baby. Clinicians should perform universal transvaginal screening at 18 to 24 weeks of gestation in women with singleton gestation and offer vaginal progesterone to those with a cervical length of 25 millimeters. A very important message for you to carry back: twin and triplet pregnancy. No benefit of any progesterone in prevention of preterm labor. So this is a very important catchy sentence which I found, and I thought, oh my goodness, what happens to these women? They would eventually go into preterm labor if whatever we use. And you understand that tocolysis with ritodine or duodenone is now out. We do not use it anymore because of the complications it can cause to mothers and the baby. I've had a very, very bad case for a patient who was on duodenone right from the first day of her pregnancy, lost her uterus, lost her baby, everything, So 17-hydroxy micronized progesterone, DHT, or the injectable, nothing is used, nothing can be used to benefit prevention of preterm labor in multiple gestation. Just the last slide, progesterone in preterm labor. This is the guideline from RCOG, ACOG, EAPM, SOGC 2016. Early prophylaxis in women who have already had a preterm labor. What do? Right from 12 weeks to 36 weeks, you would give her micronized vaginal progesterone. Mind the doses, they are very little. Do not use high doses. 10 milligrams OD at bedtime, or a Proleutin depot of 250 milligrams weekly. Short cervical length in between 18 to 23 weeks. Singleton pregnancy, micronized vaginal progesterone, 200 milligrams once at bedtime, or the gel in the morning so that she's walking around with the gel. If it is one episode of threatened preterm labor, again, vaginal micronized progesterone, 200 milligram daily to be used. Acute tocolysis, along with other tocolytics, you can add vaginal progesterone for 48 hours, which is in high doses, 400 milligram daily for 48 hours. So I end with this talk that the real voyage of discovery consists not only in seeking new landscapes, but having new eyes. And rediscovery of progesterone activities place the hormone in a key role in reproductive medicine, especially in prevention of preterm labor. With this, I would want you all to also understand that I wish we had a talk on the new use of progesterone in gynecological indications. It would really open our eyes to say how beautifully it can be used for PMS, perimenopausal symptoms, premenstrual irritation, mood swings, and everything. I would request Walter Bushnell to next year have a lecture on progesterone further to this. Thank you very much.
I would like to thank Walter Bushnell for arranging this wonderful seminar, and I thank ma'am for her wonderful deliberation. And very nicely she has spoken about the evolution of various progestogens, and the commonest use LPD, which is elusive. The diagnosis is elusive, as she has already explained very well. And talking about the sustained release preparations, that though ma'am has mentioned that the levels are sustained for 24 hours, but the levels are still very low. So that is another point that we should consider. And another very good point that she has mentioned is that for twins and triplets, where probably there is, to prevent preterm labor, where probably there is no role of any progesterone whatsoever. And very injudiciously, a lot of people go for circlage in cases of preterm labor, whereas the actual role is that of micronized progesterone. So these are the things that we should all keep in mind. Thank you so much.
Thank you, Dr. Queen. Dr. Shivani.
Thank you. So, again, thank you very much, Walter Bushnell. We cannot thank you enough because everybody is really enjoying the wonderful academic feast. And Abha, madam, that was absolutely mesmerizing. You know, we were all glued to your presentation. Thank you very much. As we all know, the first embryo transfers in IVF all failed because of one of the reasons was the wrong progesterone was used, medroxyprogesterone. So thank you very much for taking us through the journey and also, you know, pointing out that 17 alpha hydroxyprogesterone, which is used like in Maharashtra, it is called dalda ghee, and that actually doesn't work in the first trimester. Thank you, ma'am, for that wonderful presentation.
Dr. Gauri from Delhi.
Congrats to the Barlia family and Bushnell for arranging such a nice congress. I can see people coming from all over India to listen to the CME and for choosing such nice topics for this thing. Coming to Dr. Abba, as Dr. Shivani said, a really mesmerizing talk. But at the end of it, the PROMISE study says there is no use of using micronized progesterone, but all the guidelines says use it. So maybe the Bushnell family should initiate one multicentric study in India and let's see because we use it right, left and center, everybody, all the villages, second, third tier towns, second tier towns, metro cities. So maybe we can come out with some sort of a guidelines. Congrats, Dr. Awa.
Okay, thank you.
Dr.
Yeah, thank you very much for excellent lecture, Abha, and thank you, Nishant, for this wonderful opportunity. I think all my colleagues have already told that your lecture was excellent, and progesterones are actually important molecules to be used, and even the traditional L-estradiol was also useful, but the newer progesterones, you know, micronized, they have come into the way. But I remember like working in UK, maybe Caroline, I mean, we'll like your opinion, because when I worked in UK, so progesterone were not very often used in pregnancy, threatened abortion and all. They were not very popular. I don't know what's the sequence in USA, but in India, actually, progesterone are very, very commonly used for all threatened abortions, recurrent abortions, and as Shivani said, in IVF, I think progesterone are the, backbone of your this thing. So, but we must use them judiciously and the right appropriately. And but thank you for your lecture, for the excellent discussion.
I think I can make a little clarity here, JB, that progestogens were used. I think last 10 years people have seen a complete shift from progestogens to natural progesterone. 10 years or even 20 years. And now I see even the old gynecologists who were so used to of writing the progestogens, which we learned while we were students, they have all gone out of everybody's prescription. So I'm thankfully very happy that we are all into, at least in pregnancy, we don't use progestogens anymore, and therefore probably the fetal complications which could have happened have reduced dramatically.
Yeah, Professor Robert Edwards, and as he said, the first pregnancy occurred only in 1975, IVF, though the conceptions occurred much before. But they were using the androgenic progesterones.
Medroxyprogesterone.
And the medroxy one. And that's when they realized that something is going wrong. They were getting fertilization, they were getting blastocysts, but they're not getting pregnancies.
So and that is why I took you through the journey of progesterone,
that's how you saw how progesterone evolved from natural 1930s to 50s to 80s into micronized. And I don't think any one of the gynecologists sitting here must not be using progesterone for therapy.
Absolutely.
So we all use it, we overuse it,
right.
And we still have no clear-cut guidelines. Some guidelines say yes, the trials say no, so we are still confused, and we need to do our own trial in India. And I'm sure you will be getting a survey. Reshma, we are getting a survey on progesterone, Dr. Reshma. so you will be getting a survey on your mobile to tell what you're using and when you're using, and then probably we'll accumulate some data of the Indians to do it. Thank you very much for being here. Thank you very much.
So the only last message is we have clarity of using it in LPD. We have clarity of using it in preterm labor. We also have somewhat clarity in using it in threatened abortion. The only area is unexplained recurrent miscarriages where we don't have a clarity of progesterone acting and helping these women. That is where we need a research, and we need some data on that.
Thank you very much.
So after deliberating on the role of progesterones, we would like to present mementos to our speaker and all our chairpersons for this session. Dr. Abha Majumdar for her excellent presentation, and our chairpersons for their inputs, Dr. Gauri Devi, Dr. Narendra Malhotra, Dr. J.B. Sharma, Dr. Shivani Sachdev Gaur, and Dr. Queen Aditya. Thank you. And now after progesterones, we progress and move further. And we have finally reached the last session of the evening. And the topic this time is clinical experience with micronized estradiol valerate in endometrial preparations. And I would now like to invite the chairpersons for this session, Dr. Pragya Mishra Chaudhary, Dr. Surveen Ghumman, Dr. Vibhashini Prasad, Dr. Purnima Nadkarni, Dr. Maninder Ahuja, and Dr. Malvika Sabharwal. Without wasting any time, I would start introducing them. Dr. Pragya Mishra Chaudhary is consultant infertility specialist with special interest in fetal medicine at New Life Test Tube Baby Center and MGM Hospital and Research Center, Patna. She was awarded the George Mahoney Award 2014 by RCOG President Mr. David Richmond, awarded Dr. C.L. Jhaveri Award, contributed chapters in several books and national journals, held several offices and posts in Bihar Obs and Gynae Society from 2007 to 2014. Dr. Surveen Ghumman is with us. She is the director, IVF and Reproductive Medicine Center, Max Multi Speciality Hospital, Delhi. Has over 71 publications in journals and authored many books. She has received numerous awards, including Foxy North Zone Yuva Award in 2004, Distinguished Service Award, IMA 2015, certified as clinical embryologist and art specialist from Manipal University and Cleveland Clinic, USA. We also have with us Dr. Vibhasini Prasad, consultant gynecologist and infertilologist, Patna, IVF and Endosurgery Center, Patna. Her area of specializations are infertility, specialty in ART, endoscopy, and more than 2,000 couples of infertility have achieved pregnancy by ART and have been blessed with child. We have Dr. Purnima Nadkarni with us, director of Nadkarni Group of Hospitals, has 15,000 ICSI pregnancies and 3,500 IUI pregnancies to her credit, Best Consultant of Gujarat State Trophy in 2005, selected as a Power 100 Woman of Divya Bhaskar Group and awarded Gujarat Ratna Award by the then CM Shri Narendra Modi. And this is very interesting. On 11/11/11, that is the 11th of November 2011, she delivered 11 IVF babies and created a world record. Received Rajiv Gandhi Gold Medal Award for her individual achievements and national development work in South Gujarat. Received Indira Gandhi Sadbhavna Award from National Integration and Economic Council, New Delhi, in November 2013. We have with us Dr. Maninder Ahuja, Director, Ahuja Healthcare and Infertility Center, Faridabad, Secretary General of SAFOMS. She was the President of Indian Menopause Society, Vice President Foxy in 2013-14, peer reviewer of Journal of Midlife Health and Journal of SAFOMS, author of many books and several chapters in various textbooks, recipient of many awards by Foxy, National IMA, and Rotary Club FBD. And we have Dr. Malvika Sabharwal, Chief and Head of the Department of Gynae and Obs, Jeevanmala Hospital. She was conferred Padma Shri in 2008 by the Honorable President of India. She's been invited faculty in many national and international conferences and operating faculty in many national workshops. And our speakers for this session, Dr. Pratap Kumar and Dr. Praveena Rai. I request both of them to kindly join us on stage. Dr. Pratap Kumar is the Professor, Department of Obs and Gynae, Kasturba Medical College, Manipal University, Head of the Division of Reproductive Medicine at Manipal University, Inspector, Examiner, and Advisor NISA, National Board of Examinations, has more than 300 publications and presented more than 600 presentations in national and international congress, editor of 10 textbooks, awarded the Foxy Dr. Kuti Lifetime Achievement Award for 2011 and 12. And Dr. Praveena Pai, she was the assistant professor in Department of OBG, KMC Manipal, with special interest in infertility and reproductive endocrinology, and is now in Mangalore pursuing her passion in assisted reproduction. 5-year specialist training in OBG, Northwest Thames Rotation, London, consultant in Northwest London NHS Trust, London, before relocating to India in 2013, has been instructor on basic surgical skills course in UK and MRCOG course in India, conferred the Nimish Shelat Award for Endocrinology by Foxy in January 2016, conferred FRCOG by the Royal College, London in September 2017 recently in recognition of a significant contribution to the field of women's health. So without any further ado, I request Dr. Pratap Kumar to begin this session.
Very good evening to all of you. Thank the Barlia family for having invited me, Walter Bushnell, Narang, Pradeep, and all of them for having invited myself and Dr. Praveena Pai, who have done work on micronized estrogen, estradiol, valerate. I always say we have come to the last part of the session, and the most interesting hormone for a woman is estrogen. So I take you through a little bit of estrogen, what is absolutely necessary for all the women. So I always say, last but not the least, I will talk about estrogen. We bring greetings from Karnataka State, Manipal University, and we are in the west coast of Karnataka State. And the outline of our presentation for the next 20 minutes together would be on key steps of what we do, outcome modifiers, pharmacokinetics of estradiol, the role of estrogen and progesterone we are not going to touch upon because Abha Majumdar has wonderfully dealt with that, protocols for endometrial preparation, and of course various frozen embryo transfers, and finally our study done in Manipal University on micronized estradiol valerate. And obviously conclusion. We all know the key steps about IVF, basically oocyte pickup, fertilization, and embryo transfer. But we also know that a menstrual cycle has to be understood for a better result of whatever we do in infertility, basically understanding how estradiol will do the proliferation of the endometrium, and basically in the secretion phase of the luteal phase, we need progesterone, but also need the estradiol or the estrogen. So the factors affecting IVF outcome are plenty, but the next few minutes I would just probably go through the points of age, ovarian reserve, sperm parameters, oocyte quality, embryo quality, and endometrial receptivity and luteal phase support. But we all know endometrial receptivity has not been understood very well, so we would like to kind of manipulate the cycle to get a better endometrial receptivity. Now, estrogen molecule is a complicated molecule. If you look at that, we don't understand anything. As a biochemist student, as undergraduate, we didn't want to listen to these rings. But I think I understood over the years that all women like necklaces. The estrogen molecule is just like a necklace. So that's why necklaces are wanted, and the estrogen is wanted for women in all age groups. So I would like to probably emphasize by saying that all age group contraception is needed, as Madam said, but also estrogen is needed from puberty to menopause. But I would like to just emphasize on a few points on micronized estradiol valerate, because we should know that estrogen is synthesized in ovaries, adrenals, and in men also in the testes. But we also should know that there are 3 types of estrogen: estrone, which is a very weak estrogen; estradiol, which is the most strongest of estrogen for a woman; and estradiol is seen in pregnancy, but we don't bother about that. So E2, estradiol, is predominantly seen, and E1 is the menopausal estrogen, E3 is during the pregnancy. But interestingly, 98% of protein is protein bound in circulation. It goes to the liver and, of course, deconjugation in intestines. Why should we know that? Because of the enterohepatic circulation, whatever they swallow doesn't get the right concentration in the different tissues. So we have to understand what is the dose to be given for endometrial preparation in all these kind of frozen embryo transfers or IVF. Now, basically, if you look at this little complicated diagram, but I would like to make it simplified because when you look at the estrogen molecule going into the woman, it gets attached to that green thing called an estrogen receptor. But once it gets attached to estrogen receptor, the DNA molecule gets activated. When it gets activated, there are certain proteins which are released. So the micronized estradiol valerate has a very good action because it acts on these receptors. The DNA molecules are kind of broken and the proteins are the specific proteins are liberated, and these will bring the absolute change in the target organ. So the mechanism of action of estrogen would be diffuses across the cell membrane, binds estrogen receptor protein forming the so-called complex. It interacts with the DNA of the nucleus, and estrogen receptor DNA complex interacts with co-activated proteins into the target genes, ultimately transcription of mRNA and hormone-regulated genes. It sounds very complicated, but I think I understand that micronization will bring in a good action into the target cell because it brings on the right protein molecules. Now, the estrogen doesn't act on the whole body. That's what we thought long back, but it's no. It will only act on few organs in the body like the brain, the heart, the liver, breast, the uterus, and the bones. No other tissue estrogen goes and gets stuck there. That means all these areas will benefit by giving estrogen. If I would talk about menopause for another 1.5 hours, I would talk on that, but I would just take 1.5 seconds by telling that is why we give in menopause. We do not hesitate by not giving estrogen because why should she suffer? You can give estrogen, and micronized valerate is one such estrogen can be given for a number of years. However, the routes of administrations are only oral and non-oral, which are transdermal, intramuscular and vaginal. Due to a shortage of time, we will not be touching upon all these varieties of routes. But looking at the advantage of estradiol valerate, it's a natural estrogen, safer than its synthetic counterpart, the only estrogen in the micronized form because it also has a very good dissolution and bioavailability, and it esterified, preventing extensive first-pass metabolism in liver and GIT, and is easy to administer and is safer for long-term use. But because of micronization, has a better dissolution, better absorption, markedly increased bioavailability, and the desired clinical efficacy as compared to non-micronized. We were all giving this conjugated estrogen. In certain countries, it is not allowed. In India, it is still being given because it is not understood why it is not being permitted. It's not permitted in certain countries. So conjugated estrogen is coming from pregnant mare urine, whereas estradiol valerate is natural. The estrogenic activity is completely different, but the last one, the mammographic effects are no significant changes are seen with estradiol valerate. However, with conjugated estrogen, they have found mammographic changes, so we have to be a little careful in prescribing that particular product. But the blood pressure, not much of changes. By looking at the coagulation factor, conjugated estrogen increases factor 7, so you can know thrombosis may be there. However, estradiol valerate, it doesn't change. But look at the other one, ethinyl estradiol, once again is not prescribed often for menopause and other things, but it may be there in certain other forms. But looking at this very striking feature, the triglycerides goes up with ethinyl estradiol, but there is no effect of estradiol valerate on triglyceride. That's a good point. But blood pressure is different. But once again, factor 7 is increased with ethinyl estradiol. So I probably, by just a few seconds of presentation to you, I'm just once again emphasizing how estradiol valerate is the choice for a variety of reasons. Once again, talking about the other product, like synthetic hormones, are purposely designed to be more difficult for the body to metabolize and break down, so they will remain active for longer periods. Additional problems are different because the build up of molecular junk by that other kind of product will be having a problem on the body itself. But did you all know conjugated estrogen came from horse's urine, which I didn't know till about 7 years back. Now I know the estrogen coming from horse should have been given to the horse and not for the women. So I think so, because that is why it is not permitted in some countries. However, they are still promoting, which is not acceptable. The estrogen are horse estrogen. Did you all know that? Who knew that? Nobody knew. There are elements to the molecule that are normally metabolized by enzymes in a horse's body that simply do not exist in a woman. So we have been prescribing for years, and probably it can be removed from our prescription. However, regeneration of functionalis layer basically happens with estradiol valerate because there is proliferation of the gland, stroma, etc. There is celiogenesis, appearance of ciliated cells, produce cytokines, etc., immune tolerance, induction of progesterone receptors. So I think when you give estrogen, they also induce progesterone receptors. That is why in certain of these pregnancies, we also give frozen embryo transfer. We give a little bit of estrogen and progesterone. Controversial topic, let's not talk about that. But because corpus luteum produces a little bit of estrogen and a lot of progesterone. So probably these two hormones have to be thought of. This is a very interesting slide. But due to lack of time, I would just say how estrogen will change B and T cells. It affects cytokines, interleukins, etc., and etc. But that means immunotolerance is also seen with estrogen. As Dr. Abha Majumdar beautifully said, because NK activity is changed by progesterone, I for one would think by adding estrogen, we also change NK activity because it induces progesterone receptors, and both together would help us in change of NK activity. Now the principles of fresh donor egg IVF embryo transfer is basically needs coordination between the recipient and the donor cycle, achieved well with OCPs in the previous month, active month of the present cycle, where while we will do all these protocols, I will leave it to Dr. Praveena Pai to describe that. I would just emphasize by saying that in a frozen embryo transfer cycle, it all depends on good quality embryo, good endometrium for implantation, ensuring successful embryo endometrial crosstalk, and obviously apposition and addition, and of course invasion. I would request Dr. Praveena Pai to talk the next part of another few minutes on the FET protocols, natural or artificial, and so on. That's very important because there are a lot of people doing IVF cycle but are not having good response in a frozen embryo transfer cycle. So what do? I would request Dr. Praveena Pai, who's done the study with me on micronized estradiol valerate. She will also present our very short data subsequently. Thank you once again to all of you for your patient listening before the dinner.
Thank you, Pratap sir, for such an energetic presentation and setting the ball rolling. In the next few slides, I will try and take you through the frozen embryo transfer protocols, which are generally followed, and the MARC protocol, which is the Manipal Assisted Reproduction Center, what are we in particular doing. So as you can see in the diagram, FET protocols are basically of two types: the natural cycle protocols and the artificial cycle protocols. So the ones in the blue are the natural cycle protocols. These are of two types, the true NC-FET and the modified NC-FET, and I'll dwell on this a little bit. In the green is the artificial cycle FET protocols, which is what most of us are doing these days. These again can be of two types. One where we give the estrogen and progesterone, that is hormone replacement therapies, or else by ovulation induction, and the last bit I will not touch upon. So what is the rationale for choosing FET protocol? Basically, one needs to remember, if the woman has functioning ovaries, you can go for any of the protocols. But if she's got non-functioning ovaries, only artificial method using estrogen and progesterone supplement will work. So what is natural cycle FET? Essentially, the woman needs to have regular cycles. she should have proven ovulation. So basically, endocrine preparation of the endometrium is achieved by endogenous sex steroid production from a developing follicle. We are just using body's mechanism and using that for endometrial preparation. Embryo transfer is timed based on the LH surge, which can be checked either in urine or serum. And of course, luteal phase support has to follow. What are the advantages of this method? It is simple, and you don't have to give any drugs. You have to monitor for the LH surge, and once you know it is there, you can bring about your embryo transfer based on that. So you're using the natural preparation of the endometrium. But what are the disadvantages? Why is it not so popular? Even in women having regular menstrual cycles, ovulation may not always occur, and we know this when we are doing our follicular monitoring. Problem associated with detection of spontaneous LH surges do exist. There could be variation in timing of its occurrence between cycles and between patients. In order to assess the LH levels correctly, determination should be performed at least daily, preferably twice daily, and that is cumbersome both for the patients and the clinicians. LH urine kits have large variation in thresholds, which involve the risk of up to 30% of false negative testing. And if we get false negative testing, we are not picking up the LH surge, means that we think there hasn't been a surge, whereas there is a surge, and the secretory changes have already set in place. So we are messing up, and we will not be timing our thawing and replacing of the embryos correctly. So what does modified NC mean? So to overcome the disadvantage of LH monitoring, we can give HCG to initiate the luteinization. So what needs to be done here is regular ultrasound scans, and then HCG can be given on seeing a dominant follicle. Ovulation, as we know, is expected in 36 hours, so the embryo transfer can be timed accordingly. So we've gone one step ahead. We've taken away the constant monitoring of LH surge. Advantage of this particular method? Less ultrasound evaluation due to the HCG administration compared with the true NC-FET. So there's less burden on the patients and less burden on the doctors. But it is not completely foolproof. Unexpected ovulation can still occur. Accurate planning of embryo thawing and transfer is not possible consequently, and cycle cancellations in some studies have been shown in about 7 to 12% of patients. So where do we go from here? So we move on to artificial cycle FET. This may be used, as I mentioned earlier, in both functioning and non-functioning ovaries. It aims to mimic the endocrine exposure of the endometrium in normal cycle. So estrogen can be given in fixed or incremental doses, as most of the practicing people would be doing. The total duration can vary from 5 to 7 days, even up to 35 days, quotes literature. But ideally, as we all know, we are looking at about 12 to 19 days is sufficient to achieve a good endometrial thickness. Once the endometrium is 8 to 9 millimeters, certainly more than 8 millimeters, progesterone should be started. So the day the progesterone is started is considered the day of ovulation or the day of the oocyte pickup, and the time of thaw and transfer is determined accordingly. Route of progesterone can be vaginal or intramuscular, it does not matter, so says the literature. Luteal phase support should be given with estrogen and progesterone for 10 weeks after she is confirmed beta-HCG positive. So what are the advantages of this protocol? There's greater control and flexibility in the timing of transfer cycles. The cycles are easier to plan. It's popular among patients and their doctors consequently. The length of follicular phase can be varied without detriment to the implantation rate or the pregnancy rates. I mentioned earlier, the duration does not matter as long as we are aiming for an 8 millimeter endometrial thickness. So that can vary. Cycle cancellation rate is low, higher in implantation and pregnancy rates than in patients with natural cycles. But there are disadvantages again. Unlike NC-FET, it requires medications. Clearly, we have to give medications here. Administration of estrogen and progesterone does not guarantee complete pituitary suppression. And we all know that one particular follicle which comes and nags us at the end. A dominant follicle may still occur in 5% cases. Should the follicle undergo spontaneous luteinization, endometrium may be exposed to progesterone earlier, hence incorrect timing of thawing and transferring. So that made us move to something else, and that is AC-FET with GnRH analogs. Sorry, the A is missing here. So AC-FET, so artificial cycle FET with GnRH analog says what? Here, the GnRH analog is used to suppress ovarian function temporarily prior to inducing an artificial cycle with estrogen and progesterone. What's the disadvantage? it's more expensive because you're adding that extra GnRH analog, but it doesn't really matter. As I'll come to the MARC protocol, you'll see in a moment. GnRH analogs can have side effects, the most important being there can be delay in the resumption of spontaneous ovulation if the FET fails. She may not get a period for the next 2-3 months, and that becomes quite, leaves patients quite distraught at times. So, just a word of caution. There was this paper which came out, Endometrial Preparation for Women Undergoing Embryo Transfer with Frozen Embryos or Embryos Derived from Donor oocytes. And this was a Cochrane review, which said what? No one protocol is superior to other in terms of pregnancy rates. Lower pregnancy, the only thing they concluded here was there are lower pregnancy rates if progesterone was started prior to the oocyte pickup as compared to on the day or after the day of oocyte pickup, ideally on the day of OPU. So that was the only conclusion. There was no protocol which was superior, is what they concluded. And similarly, more recently in 2013, we've got this Greenwald systematic review and meta-analysis, a beautiful meta-analysis which concluded similarly, all current methods of endometrial preparation appear to be equally effective. However, many retrospective studies were included in this meta-analysis, patient perspectives and cost effectiveness was not assessed, and hence they have suggested larger, more robust studies. Moving on, I'm aware of the time and I will have to request an additional 2 minutes from the chairpersons. What is our protocol? For fresh donor egg IVF, in the month prior to the embryo transfer, ovarian suppression is done using OCPs. On day 18 of OCPs, we do transvaginal ultrasound scan. If the ET is very thin, then we do not give GnRH analog. But if it is okay, we do give that additional GnRH analog to ensure no follicular activity in the subsequent month. From day 2 of menses, we start the Estradiol Valerate, 2 mg 3 times a day, check the transvaginal scan in a week's time, and increase the dose if necessary. Once endometrial thickness is 8 millimeters, which we have found is usually achieved within 14 days of estradiol, we start the progesterone. We are using intramuscular, but a lot of people have switched to vaginal, as Madam very beautifully elaborated. This corresponds to the OPU in the donors. In case of transfer of day 3 embryos, 3 days of progesterone, and in cases of day 5 transfers, 5 days of progesterone is given. Beta-HCG is checked 2 weeks after the embryo transfer, and LPS is given in the form of progesterone and estradiol valerate for 10 weeks, as I mentioned earlier. So this is what it is. So start OCPs, day 18 GnRH analog, day 2 start estradiol, ET, once we've 8 millimeters, start progesterone and then embryo transfer. So altogether, if you know the day of ET, so when you want to time your cycles of the recipient and donors, if you know what day you're doing ET, you're going backwards about 45 to 46 days to start the OCPs in your recipients. Roughly, that's how we calculate. What is the FET protocol? As I mentioned earlier, day 21, we just give the GnRH analog, half dose. Day 2, we start the estradiol. Once the endometrial thickness is 8 millimeters, start the progesterone, and the embryo transfer is done on day 3 or day 5. So what was this small study Sir mentioned? Basically, this was to determine the efficacy of micronized estradiol valerate in improving endometrial thickness in women undergoing donor egg IVF. It was a prospective, open-label, uncontrolled drug utilization study to evaluate the role of micronized estradiol valerate in endometrial priming. This was done over slightly extensive period, November 2015 to 2017, 50 cases. The reason being some of the cases where we had prepared them, but if we did not get sufficient number of oocytes, we had to cancel those cases. And that's why it was a slightly extended time frame. Indications for donor egg, as we all can see, could be ranging from premature ovarian failure, poor ovarian reserve, repeat IVF failures of 2 or more, recurrent pregnancy losses, and frankly, postmenopausal ladies. So we're looking at 2 outcome measures. Primary, to analyze the endometrial priming with the drug by measuring the difference in the endometrial thickness on a transvaginal scan by a single operator. And secondary, to determine the pregnancy outcomes in terms of clinical pregnancy, abortions, and live births. What did we find? We found that the endometrial thickness difference that we found, the mean difference was 3.5 millimeters, and it ranged from as less as 1.1 in one particular case to about 7 millimeters. So overall, the improvement that we found was quite good. Endometrial pattern, the 3 patterns that we were looking at, triple line was found in about 45 cases, isoechoic, none of the cases, and homogeneous echo texture was in 5 cases. The mean dose of estradiol valerate, which is required in our cases, was 82.8 milligrams, and the range was from as less as 64 to 118 milligrams. We had transferred ranging 2 to 4, we have moved away from 4 embryos. We tend to go for 2 or 3, but average was 2.76. And we got 28 out of these 50, 28 beta-HCG positive cases. What happened with these? There was 1 biochemical pregnancy, 7 resulted in abortions, 12 live births, and 8 are still ongoing, which gives us a clinical pregnancy rate of 54% and a live birth rate of 42.8, which is quite commendable, I think. Of course, the study is very small. It has its limitations. We had included both fresh and frozen embryo transfers. Various confounders were not accounted for. Vaginal route of administration was not used. And other parameters of endometrial receptivity like blood flow, etc., was not tested. So it was a very simple observational study. So what was the inference of all this? Jury, we know, is still out about the best method for frozen embryo transfer. Progesterone for luteal phase support, whether intramuscular, vaginal, or oral, all are equally effective. Estrogen, micronized oral estrogen has definite advantages. Transdermal has its supporters too. Vaginal estrogen, unlike what Abha madam talked about vaginal progesterones, vaginal estrogens may produce too high levels in the endometrium, and there is a thought that this may prove to be counterproductive for endometrial receptivity. So they're not, at the moment, we don't have huge takers for vaginal estrogen, unlike the vaginal progesterone. So finally, good improvement in the endometrial thickness was achieved with micronized estradiol valerate. Good pregnancy outcomes were seen. And it's important, as Dr. Pratap said, to understand the physiology of ovulation and manipulate cycles for better results. Thank you very much for patient listening. The dose used to start with 2 milligrams 3 times a day, madam. After a week, we do a scan and see. If you're thinking that it is going towards a good 6-7 millimeters, we continue the same dose.
So, first of all, I would like to thank Walter Bushnell for the overwhelming hospitality and nonetheless, for this scientific bonanza which they have offered to us. And especially it's marvelous, how they've brought together all the stalwarts in obs and gynae on the same day and all of them together on the same evening. So that's really marvelous, And of course, both the speakers in this session have done a wonderful job, with their subjects. Especially Dr. Pratap Kumar has, explained and highlighted all the advantages of micronized estrogen over non-micronized estradiol. And it seems that in the time to come, this micronized form of estrogen will actually serve to be a boon for us, because of the reduced side effects. And as he mentioned, the increased bioavailability and absorption and dissemination. And with really, so I think, and besides, I think we may be able to use a higher dose without increasing the side effects, especially for endometrial preparation. And secondly, Dr. Praveena Pai, her talk was in fact really wonderful. I mean, especially, you've dealt with all the, the FET protocols, the natural cycle and the artificial cycle protocols. And of course, your experiences with micronized estrogen in your hospital. So indeed, it was wonderful. So I hand over to my colleague now.
As usual, I think this annual event of Walter Bushnell spells quality, both in terms of the speakers and the content of their talk. And it's always a pleasure being here. Thank you so much for that, the Walter Bushnell family. Dr. Pratap's talk, of course, was excellent as usual. And he made a very good comparative analysis between Valerate and the other forms of estrogen. Praveena presented the data excellently, and where I would like to comment here is my clinical experience. There's one observation which I've made, which is that there's a sect of patients who differ in their response in each cycle as far as estrogen is concerned. You're forming the endometrium, one cycle may not form well. The next cycle with the same drug may form very well. And what I realized was that stress plays a very important role. It's not just in ovulation, but even in forming the endometrium. And I always quote this particular example of my patient. There was this donor cycle happening, and I canceled 3 cycles because the endometrium was not going beyond 5 mm each time I gave her the estradiol. The fourth cycle, the husband came and told me, he says, you know, we were in a joint family and we've shifted, and I made her totally stress-free. And that cycle, she made a 9 mm endometrium, and she conceived and delivered. So I personally feel that stress is an important part in response to the estradiol. Over to Dr. Purnima.
Yeah, she said it so well. We do have patients, in spite of down-regulating nicely and giving estrogen, they do not do very well. And sometimes such patients, I had one patient last month, she did very well only in natural cycle. And down-regulated cycle, her endometrium was not coming more than 7 millimeter. So, as you said, stress level makes a big difference. And for the perfect implantation, you require embryo quality also very good. They were talking about frozen embryo. Embryo quality, the endometrial receptivity, and the crosstalk between two is very important. I think we should consider all these factors when we talk about our pregnancy rates.
In routine practice, what we do is the TVS, that is transvaginal sonography, the day 2 baseline scan, and day 7 or 8 or 9, we go for we want to found what? That is the trilaminar layer, and that is the most common problem when really we feel that, oh no, the endometrium is very thin and we are not getting it. So what should be the actual, whatever she has mentioned, that is really good, but what commonly used and what we are using commonly, especially myself, especially in cases of FET or oocyte donation program, I use hormone therapy cycle, and that is right dose with right estrogen with escalating dose of micronized estradiol, Valerate of course, for adequate period, and that too minimum for 7 to 10 days. So this is the thing, after exclusion of course, the health of endometrium, it is necessary, and even in number of cycles where with the supplement of estradiol, we have got the pregnancy, and really it has helped a lot.
Thank you, Walter Bushnell and Satyapal Group, for bringing faculty and delegates from east, west, north and south. I think that's a great thing they have done here. And Dr. Pratap, he's as usual a great speaker, and I must say you are acquiring the status of now teacher of teachers now. And his talks are really excellent, from the basic to the illustrative type. And Dr. Menarche has been very nice. And as he said, yes, estrogens are like a necklace to a woman. So that necklace is required from the very early childhood, or even from embryological period to later on menopause. The only thing, because being a menopause specialist, what I always say is that estrogens, they have to be used judiciously within the window of opportunity. Because when we are doing embryo transfer beyond the age of 60 years or beyond 10 years of menopause, we should be very careful in evaluating these patients for IVF before giving them these long periods of estrogens. That's very important, and he has already. And what work I think Walter Bushnell should be doing in future is role of micronized estradiol vaginal. Vaginal might have a great potential, because vaginal will be acting on the uterus itself, and perhaps it won't be absorbed. And then when we are doing embryo transfer in later on age group, that will be much more helpful. So that is one area where we have to give, I think, thoughtful to, like he said, we should be doing. And again, thanks to the Walter Bushnell for excellent presentations from evening itself. We didn't feel the time at all.
Good evening, everybody, and I think we are at the end of the day. And let me congratulate Nishant Barlia, the whole Barlia family, Walter Bushnell, and the whole team, Walter Bushnell team, to have put forward most pertinent topics. And let me tell you that Dr. Pratap Kumar rightly said, estrogens are the hottest that we all need to know about. And you kept it for the end, which is so important. Everybody's here and everybody is hungry. So we will not, And, we know that Dr. Pratap Kumar, an excellent academician who's put forward so beautifully the subject so clearly of this topic, wherein we all land up, wherein, the endometrium just doesn't get formed. And you want to have the best. And with his experience, I would just like him to highlight, in case, what is the prime difference that he's seen and what is his experience of breakthrough bleeding while using both the micronized form and the Progesterone, what we've been using. Yeah. Also, let me congratulate Punita. Excellent talk. Really very well done.
I think the breakthrough bleeding was seen before. If you know the right dosage, I think with the micronized estradiol valerate, we are not finding breakthrough bleeding. It's a very important observation.
Okay, excellent. And I think now everybody is very hungry. Thank you and congratulations, Walter Bushnell.
I request Mr. Nishant Barlia to kindly present mementos to all our chairpersons and speakers. Just 2 more minutes, ladies and gentlemen. We have vote of thanks coming up. Well, the kind words and appreciation of our endeavor by the eminent chairpersons and speakers here is very heartening, and we at Walter Bushnell thank them profusely for the same. Well, as the hormones progesterone and estrogen are vital to life of women, one hormone which is vital for the life of both men and women, which is the elixir of life, and in your language, which is which has therapeutic effects, that is music. So, ladies and gentlemen, before vote of thanks, I request you to kindly enjoy the music which is being rendered this evening by Gary. He has a wide repertoire, and while you have your cocktail and dinner, don't forget to enjoy his music. And vote of thanks now by Mr. Vikram Narang, DGM Marketing, Walter Bushnell.
Thanks for calling my name on behalf of this lovely evening. Special, please carry on.
So it is my great privilege and pleasure to express our gratitude to the top dignitaries. I think everybody is moving to have a dinner. Nobody is listening to the vote of thanks. But then also I would like to thank all, because we were having the top 20 dignitaries as a chairperson, international delegate from US, Dr. Caroline, and more than 400 guests. So I would like to clap for all of you. इस मौके पे एक शेर पढ़ना चाहता हूँ. आसमान में हैं कई सितारे, आसमान में हैं कई सितारे. That means more than 30,000 gynecologists are there. But Walter Bushnell Healthcare Foundation ने आज चुनकर बेस्ट ऑफ सितारे यहाँ हैं उतारे. So again, congratulations. And special thanks to Madam Sushma Barlia, Mr. Nishant Barlia, and Dr. Neha Barlia for their presence in this event. And just to remind you that tomorrow there will be Dr. Satya Paul Awards, 6th edition of IOG, and there will be an oration lecture by Dr. Caroline. That will be a pill in time saves 9. Now we can enjoy cocktail dinner. Already we are enjoying, I think. So again, once again, thank you very much for coming and making this event very successful. Thank you very much.
I just need a big hand for the lovely, this members, family, please put your hands together for the lovely evening on the behalf of lovely members. आ गया मैं आ गया. मत हो ये जा